Halo dokter, salam sehat bersama. Jumpa lagi dengan saya Bung Infusan.
Sabun cunya dimakan api, dimakan api. Tabang bamban jangan diparit, mun diparit buang ke sumur, buang ke sumur. Luka nang di tangan, kawan di baban, luka nang di hati, hancur sekali. Sapu tangan babuncu empat, sabun cunya dimakan api, dimakan api. Tabang bamban jangan diparit, mun diparit buang ke sumur, buang ke sumur, yeah. Rindang pangdandang jangan diharit, lamun diharit membawa umur. Oh no, yeah. Sapu tangan, sapu tangan babuncu ampas. Oh yeah, sapu tangan babuncu ampas. Oh yeah, sapu tangan, oh yeah. Tarik cel, nyaman benar kene bakayuhan lah. Oh banyak, itu nah benar untai-untai dalam tapeh tuh. Luka nang di tangan, kawan di baban, luka nang di hati, hancur sekali. Rindang pangdandang jangan diharit, lamun diharit membawa umur. Gugurnya melintang mencari si jantung hati. Aduhailah sayang, daun si daun dadap, daun dadap gugur melintang, daun si daun dadap, daun dadap gugur melintang. Gugurnya melintang, basunting si kambang melati. Gugurnya melintang, basunting si kambang melati. Aduhailah sayang, jantung hati. Basuhlah bintang mencari si jantung hati. Sayang, bulan si bulan kadang, bulan kadang basuhlah bintang, basuhlah bintang mencari si jantung hati. Basuhlah bintang mencari si jantung hati, mencari si jantung hati. Panas menggantang, angah hari menggantang, panasnya menggantang. Rasa rakai tulang hingga sampai ke pinggang, mengilik nanang galu caramin matanya. Batulah mencari akan rezekinya. Guntur kilat bersambung, hujan labat arus deras wan galumbangnya. Awak basah kedinginan di tengah sungai. Abah malunta baluma tentu pakulinya. Abah batulah mencari akan rezekinya. Tangan Abah nak melindungi. Ampuni aku namaku Umaratu ai Abah Raja ai Allah Umma Allah Rabbi firli wali walidaya Rabbi firli wali walidaya Ampuni akam dosa umma wan abahku Ampuni akam dosa umma wan abahku Ampar pisang, pisangku lalu masak sabiki dihurung bari-bari.
Your Excellency, ladies and gentlemen, we cordially invite you to be ready.
Because in a few minutes, the event will proceed in no time. Thank you.
Bengkok dimakan api, apinya kasurupan. Bengkok dimakan api, apinya kasurupan. Nang mana batisku tuh dikit pidawang. Nang mana batisku tuh dikit pidawang. Ampar pisang, pisangku lalu masak sabiki dihurung bari-bari. Masak sabiki dihurung bari-bari. Manggarepang patah kayu bengkok, bengkok dimakan api, apinya kasurupan. Bengkok dimakan api, apinya kasurupan. Nang mana batisku tuh dikit pidawang. Nang mana batisku tuh dikit pidawang.
Good morning, Dr. Chong Chintek,
Good morning, Dr. Himawan Sosongko.
Dr. Iputu Pramana Swarjaya.
Good morning, Dr. Kenanga.
Good morning, Dr. Leong Kok Weng.
Good morning, Professor Tatang Bisri. Thank you for your presence.
Good morning, Dr. Leong. I'm Putu from Bali.
Selamat pagi, Dr. Putu. Bisa dengar saya, Dok?
Siap, Dok?
Ya. Kok gambar saya nggak bagus ya? Virtualnya.
Perlu Dok, green screen belakangnya.
Oke.
Selamat pagi, Mas Himawan, Dr.
Pagi,
Dani.
Dr.
Selamat pagi, Mas Putu.
Selamat pagi semuanya.
Selamat
Good
pagi,
morning
Prof.
everybody.
Selamat pagi.
Selamat pagi, Prof.
Pagi Dr. Putu, Dr. Dadi, good morning Dr. Cynthia, Dr. Lengkokwen. It's nice having you today. Dr. Himawan kayaknya background-nya jadi kayak penampakan gitu ya?
Iya, gimana ini?
Boleh kalau dokter ini dok nggak usah pakai virtual background. Ya. Kita pengen ngelihat Dr. Himawan gitu kan?
Terima kasih.
Kalau ini komputernya tidak support, jadi harus pakai green screen.
Oh. Mau ganti laptop kok sudah waktunya udah nggak nyampe.
Yuk, masuk kan yuk.
Banjarmasin, nandingarani kota seribu sungai. Ayo ka Banjarmasin, kota nang tapandang, wanang paling bungas. Ayo ka Banjarmasin, nandingarani kota seribu sungai. Ayo ka Banjarmasin, kota nang tapandang,
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone.
Thank you to all panelists, moderator, and participants.
We are very grateful for your presence, for being able to attend our second day on our big event. Second, Biennial Neuro ICU Symposium. Second, Joint Symposium Neuro ICU Indonesia and Singapore. Improving patient outcome from basic to advanced technology in neurocritical care.
Are you still excited today?
I'm very excited for today, because today there were speakers from various countries who were no less interesting than yesterday.
And of course, the topic to be presented were very useful and up to date.
First of all, before we are started this big event, we invite you to pray first, please, so this event can run smoothly and perfectly.
Please pray according to your respective religion and belief. Pray, please.
Thank you. Move on. As for today's series of virtual Symposium Neuro ICU event consists of 2 sessions, cerebrovascular, brain and spinal cord, and also closed session.
As previously, we will read some rules. First, send in your question and comment via the Q&A section.
Second, chat and raise hand functional are disabled.
Third, our moderators will highlight your question to the appropriate speaker during panel discussion.
Before we entering our agenda,
we proudly present Baksa Kembang Dance from South Kalimantan. Baksa Kembang is a traditional dance to welcome people.
So we are very glad to have you all here.
Okay, for the first session for today's plenary lecture, we will introduce those who act as speakers and moderator.
We have 4 speakers. Dr. Sudadi, Neuro Anesthesiologist Consultant, Regional Anesthesiology Consultant from Indonesia.
Dr. Chong Chin Tet from Singapore.
Dr. Leok Kok Weng from Malaysia.
Dr. Iputu Pramana Suarjaya, Neuro Anesthesiologist Consultant, Pain Management Consultant, Master of Public Health from Bali, Indonesia.
As for the moderator, Dr. Himawan Sasongko, Neuro Anesthesiologist Consultant, Master of Biomedical Science, Master of Public Health Science. Before we hand over the host to the moderator, allow us to read a little CV about him.
He was graduated from Medical Faculty of Diponegoro University. Then he continued his study Master of Biomedical Science, Master of Public Health Science, and as an anesthesiologist at Diponegoro University, and expanded his studies as Neuro-Anesthesiologist Consultant at Pajajaran University.
Now, he served as Staff Department Anesthesiologist and Intensive Therapy at Dr. Karyadi Hospital, Semarang. We welcome you, speakers and moderator. To Dr. Himawan, time is yours.
Thank you. Bisa dengar suara saya?
Bisa, Dok.
Ya, terima kasih. Oke. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good luck to all of us. Good morning, ladies and gentlemen. Welcome to the second Biennial Neuro ICU Symposium and second joint Biennial Neurosymposium Indonesia and Singapore. The topic of the first session of the second day of the symposium this morning was cerebrovascular. Yeah, this morning we have 4 speakers. The first speaker is Dr. Sudadi from Yogyakarta, Indonesia. The second speaker is Dr. Chong Chin Tet from Singapore. And the third speaker is Dr. Leong Kok Weng from Malaysia. And the last speaker was Dr. Iputu Pramana Suarjaya from Denpasar, Indonesia. If you have any question, you can write them on the chat the column provided. Your question will answered in the discussion session after all of speakers presented the topic. Yeah, for the first speaker, Dr. Sudadi, the title of presentation is Acute Ischemic Stroke in the Neurocritical Care. Dr. Sudadi is from Yogyakarta, Department of Anesthesiology, Intensive Therapy, Gajah Mada University, and the degree of Neuroanesthesia and Critical Care Consultant obtained from University of Pajajaran, Bandung, Indonesia. To Dr. Sudadi, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Himawan, for nice introduction. Let me speak in Bahasa Indonesia. Yang saya hormati para guru besar dan sejawat sekalian, sebelumnya izinkan saya untuk share screen. Oh, nampak ya. Apakah nampak, dokter?
Sudah, dokter.
Oke. Ya. Oke, yang saya hormati para guru besar, para sahabat sekalian, saya dapat tugas menggantikan Dr. Gaus yang pada hari ini berhalangan karena sakit. sehingga saya coba untuk mempresentasikan, kami bikin bersama untuk materi mengenai acute ischemic stroke in the neurocritical care unit. Sahabat sekalian, seperti kita ketahui bahwa stroke ini merupakan hal yang sangat tinggi insidensinya. Nanti akan saya sampaikan beberapa, ini outline-nya adalah mengenai introduction, kemudian saya sampaikan mengenai epidemiologi stroke, baik secara global maupun lokal, kemudian bagaimana acute ischemic stroke sendiri dan tata laksana yang harus dilakukan. Ya. Bapak Ibu sekalian, stroke ini adalah suatu sindrom yang berkembang dengan cepat, ya, dan mungkin dalam hitungan detik sampai menit, dan ini bermanifestasi dalam satu gejala hilangnya fungsi dari susunan saraf pusat baik lokal maupun secara global. Dan simptom ini kadang-kadang berlangsung dalam 24 jam atau bahkan lebih, dan bahkan berakhir dengan kematian, dengan penyebab utama adalah karena gangguan vaskuler dan mungkin juga gangguan dari pembuluh darah di sini. Nah, kalau kita lihat dari epidemiologinya, stroke ini 1 dari 6 penduduk selama hidupnya ini bisa berkembang menjadi stroke. Jadi potensial sekali, hampir 1/20 ya, bisa berkembang menjadi stroke. Dan lebih dari 13,7 juta mengalami stroke setiap tahun, 5,8 juta pasien meninggal karena stroke, dan lebih dari 80 juta orang yang selamat. Nah, hanya saja insidensi stroke ini 80% karena iskemik dan 30% karena hemoragik. Sayangnya yang hemoragik ini walaupun hanya 30%, seringkali berujung pada kematian yang lebih tinggi. Ya. Kalau kita lihat di Amerika ini angkanya lebih detail lagi, bahwa ini merupakan penyebab kematian kelima utamanya, dan dalam setiap tahunnya angka kejadiannya cukup tinggi sampai 800.000 dan membunuh hampir 130.000 penduduk Amerika. Dan biaya perawatannya luar biasa, 34 sampai 40 billion dolar setiap tahun ini. Kalau kita lihat di Indonesia, ya, di Indonesia angka kejadian stroke berdasarkan research baseline dari Kemkes, ini kejadiannya 10% dari seluruh penduduk. Kalau berdasarkan provinsi, Kalimantan Timur ini tinggi, kemudian Yogyakarta. Nah, Jogja ini mungkin karena banyak pensiunan yang datang ke Jogja, artinya orang-orang tua yang berdomisili di Jogja, sehingga angka kejadian stroke cukup tinggi. Kalau kita lihat umur, ya, lebih dari 75 tahun, itu kejadiannya 50,2%. Ya, sangat berhubungan dengan misalnya penduduk suatu wilayah di situ banyak usia yang geriatri, misalnya orang-orang yang pensiun, nah itu kemungkinan stroke-nya akan tinggi. Sedangkan berdasarkan jenis kelamin, laki-laki lebih tinggi dibandingkan dengan wanita. Ya. Kalau kita lihat secara keseluruhan klasifikasi daripada stroke, ya, hemoragik ini sekitar tadi antara sekitar 30%, tapi yang berdasarkan dari referensi yang saya ambil, ini ada 12% karena hemoragik, sedangkan yang lain itu 88 karena ischemic stroke. Nah, artinya bahwa kita akan lebih banyak menghadapi pasien-pasien ischemic stroke daripada yang hemorrhagic stroke. Ya. Ya. Acute ischemic stroke sendiri ini disebabkan karena suatu emboli yang menyebut pembuluh darah otak dan yang mensuplai area tertentu. Dan di sini didefinisikan karena sumbatan ini menyebabkan daerah yang tersuplai ini menjadi gangguan neurologik yang kemudian diikuti dengan manifestasi klinis ya, yang seringkali memerlukan pertolongan. Nah, ini mempunyai imbas baik sosial ekonomi maupun ya klinis ya. Dan ini tentu menjadi perhatian bagi kita semua untuk bisa menangani dengan baik ya. Atau kalau kita lihat di sini, misalnya ada sumbatan di daerah tertentu, tentu lokasinya akan sesuai dengan daerah yang disuplai ya. Apakah itu di daerah arteri yang di luar yang menuju ke otak ataupun mungkin di dalam otak sendiri. Ya. Ini gambaran sirkulasi dari cerebral. Cerebral ini disuplai oleh arteri karotis yang anterior maupun yang posterior, yang kemudian ada sirkulus nuclei. Nah, di sini kalau misalnya ada hambatan pada daerah yang anterior, tentu daerah anterior yang akan kena. Nah, oke. Nah, ini kalau kita lihat pada sirkulasi anterior, daerah frontal yang akan kena. Sedangkan posterior di daerah occipital yang akan kena di situ. Nah, manifestasi klinisnya tergantung dari suplai darah yang mengalir. Misalnya dari arteri karotis internal. Ya, ini bisa kena daerah hipokampus, daerah global pelvis, daerah kapsula internal. Sedangkan di daerah belakang yang dialiri oleh arteri vertebra cabang dari arteri vertebralis, ini bisa ke daerah medula atau daerah cerebellum ya, yang dialiri oleh arteri cabang dari basilaris, bisa daerah pons maupun daerah cerebellum. Jadi tergantung dari daerah yang tersuplai di situ. Ya. Stratifikasi dan etiologi dari stroke berdasarkan stratifikasinya, ya, stroke ini bisa terjadi ataupun kausanya bisa karena hambatan atau sklerosis pada arteri yang besar, bisa karena emboli karena faktor kardiak, ataupun oklusi dari arteri kecil, ya, ataupun mungkin sebab yang lain, ya. Dan tentu di sini akut ischemic stroke ini yang hal-hal tersebut itu yang mendasari kejadian-kejadian stroke-nya. Nah, penyebab yang lain bisa karena diseksi ekstrakranial arteri maupun stroke karena subarachnoid hemorrhagic, ini karena yang menyebabkan spasme dari vaskuler. Ya. Kemudian bisa juga karena faktor herediter, keturunan, faktor infeksi, dan juga faktor koagulopati. Dan ini yang akan menyebabkan stroke-nya. Oke, patofisiologinya sebetulnya kompleks, ya. Tetapi intinya adalah kalau ada obstruksi di daerah cerebral, ini akan menyebabkan area iskemik. Ya. Di tengahnya akan ada suatu area yang mungkin bisa sampai nekrosis, dikelilingi oleh daerah iskemik yang disebut area penumbra. Nah, area penumbra ini mungkin bisa kita selamatkan, tetapi di daerah yang iskemik, di daerah sentral, ini sifatnya adalah irreversible. Oke, kalau kita lihat dari sign-nya ataupun tandanya adalah kalau ini sumbatannya berasal dari arteri cerebral anterior, akan terjadi kelemahan pada anggota, mungkin tangan bagian anggota gerak bagian atas ya, yang kontralateral, dan juga diikuti dengan kelainan perilaku. Nah, sedangkan pada arteri cerebral medialis ini bisa kelemahan kontralateral pada daerah muka dan tangan, ya, mungkin ada gangguan bicara, gangguan penglihatan, dan juga bisa terjadi gangguan stimulasi, baik sensoris, ya, akan terjadi penurunan dari sensoris. Sedangkan kalau sumbatannya atau gangguannya ini pada arteri cerebral posterior, akan terjadi defisit dari penglihatan, hemianopia, dan juga sensorisnya. Nah, ini juga nanti akan bisa berimbas ya kalau pada sistem vertebrobasilaris ya bisa terjadi ataksia, kemudian juga akan ada gangguan pergerakan pupil, sedangkan kalau ada gangguan pada vena ini bisa terjadi penurunan dari kesadaran. Ya, diagnosis dari stroke ini bisa kita tegakkan melalui anamnesis, kemudian pemeriksaan fisik, pemeriksaan tambahan, kemudian mungkin dengan diagnostik teks yang lain, maupun yang lebih berperan di sini adalah dengan imaging ataupun radiologis. Ya. Untuk radiologis sendiri, perkembangannya sangat luar biasa, baik yang imaging yang basic maupun CT scan, MRI, dan sebagainya. Dan ini sangat mendukung untuk bisa mendiagnosis stroke ini dengan lebih presisi. Manajemen dari stroke ini tergantung dari kausa mana yang mendasari, apakah itu karena obstruksi ataupun karena emboli. Ya. Tentu di sini ada manajemen untuk tekanan darah, reperfusi terapi, oksigenasi dan ventilasi, kemudian pengaturan dari gula darah, pengaturan temperatur, posisi, nutrisi, kemudian terapi koagulopati, manajemen dari perdarahan yang mungkin terjadi, kemudian juga pengelolaan terhadap kejang yang terjadi, dan penting juga dilakukan neuromonitoring selama terapi dilakukan. Ya. Satu persatu ini adalah suatu algoritma yang bisa dijalankan pada saat kita menerima pasien stroke. Ya. Jadi apakah stroke itu kurang, misalnya kita datang ke rumah sakit kurang dari 5,5 jam, mestinya harus segera dilakukan head CT scan, hasilnya seperti apa, ya. Mungkin bisa kita berikan obat untuk fibrinolitik dulu. Nah, ini sesuai dengan protokol yang mungkin ada sesuai dengan guideline. Ya. Nah, sebaiknya pasien-pasien yang mengalami akut ischemic stroke ini dirawat di ICU. Utamanya adalah di unit stroke yang memang betul-betul di situ dikhususkan untuk pasien neuro. Ya. Walaupun sebetulnya tidak ada bukti yang pada kondisi yang minimal itu tidak ada bedanya sebetulnya dirawat di ruangan biasa, tetapi pada kondisi tertentu perawatan di ICU ini akan lebih memungkinkan outcome-nya lebih baik. Ya. Yang pertama adalah pengelolaan tekanan darah. Nah, standarnya sesuai dengan konsensus, ya, tekanan darah sistolik ini kita manage di bawah 180 mm Hg untuk sistolik, sedangkan diastolik ini 110. Ya. Tentunya di sini harus kita pikirkan kalau pasien sudah menerima fibrinolisis terapi, dan tadi bahwa ini sebenarnya golden period-nya sekitar 3-6 jam, ya. Ini kalau tensinya itu cukup tinggi, risiko perdarahannya juga akan meningkat. Nah, sehingga kita harus manage betul. Biasanya pasien stroke ini tensinya kan di atas 200, harus kita manage sebisa mungkin di bawah 180. Ya. Pada guideline yang terbaru justru malah kalau bisa sekitar 140. Ya. Ya, sama sebetulnya kalau tekanan darahnya ini cukup tinggi, perlu kita menggunakan terapi. Rekomendasinya adalah dengan labetalol ataupun dengan nikarpidin. Ya. Jadi kita bisa memberikan dengan dosis 10-20 mg intravenous, ya, dalam waktu 1-2 menit, kemudian bisa diulang. Ya. Nah ini kalau misalnya tekanan darahnya masih tetap tinggi, kita bisa mengadjust dosisnya dengan dosis yang lebih tinggi. Ya. Oke, ini adalah rekomendasi. Ya. Kalau pasien dengan datang pada kondisi hipotensi dan hipovolemi, ini harus segera ditata laksana atau dikoreksi. Ya. Terlalu rendah tidak baik, terlalu tinggi juga tidak baik. Rekomendasinya adalah sekitar 140 sampai 180 sebetulnya. Ya. Ini masih rekomendasi untuk pengelolaan tekanan darah, ya. Jadi pasien dengan hipertensi harus segera ditreatment di bawah 180. Ya. Ini level of evidence-nya cukup bagus, ya. Treatment bahwa pasien harus dikelola tekanan darahnya. Oke, ya. Ini adalah obat-obat yang bisa dipakai, labetalol, nikalpidin, ya, levetidin, dan obat-obat yang lain. Ya. Oke, nah oksigenasi. Oksigenasi ini penting sekali pada pasien dengan kondisi hipoksia. Tentu outcome-nya akan menjadi jelek. Ya. Tetapi suplemen oksigen, ya, ini hanya diberikan kalau SpO2-nya kurang dari 94% pada pasien dengan room air napasnya. Ya. Tetapi kita harus memonitor terus. Kalau misalkan SpO2-nya semakin turun, harus segera diberikan suplemen oksigen. Kalau terjadi penurunan tekanan, penurunan kesadaran sampai GCS di bawah 9, tentu protokolnya sama, harus tetap dilakukan intubasi. Ya. Kita tidak boleh membiarkan pasien dalam kondisi hipokapni. Ya. Hipokapni dengan tekanan PCO2 kurang dari 35, ini sangat berhubungan dengan outcome yang kurang baik. Ya. Lebih dari sepertiga pasien dengan akut ischemic stroke ini memerlukan tracheostomi, utamanya pada pasien dengan prolong intubasi, prolong mechanical ventilasi. Ya. Dan pada pasien dengan tracheostomi, early tracheostomi sebetulnya itu justru outcome-nya lebih baik. Ya, ini adalah rekomendasinya. Ya. Jadi kita perlu airway support dan ventilation support pada kondisi-kondisi tertentu. Ya. Dan suplemen oksigen, ya, untuk memaintain saturasi oksigen di atas 94. Ya. Kemudian untuk pengelolaan gula darah. Ya. Hiperglikemi setelah akut ischemic stroke, ini harus kita reduce, harus kita kurangi, harus kita atur sampai normoglikemi sekitar 70 sampai 140. Ya. Dan kita juga harus mencegah supaya tidak terjadi hipoglikemi. Ya, hipoglikemi di bawah 60, ini outcome-nya akan menjadi sangat jelek. Ya. Dan tentu untuk pasien-pasien dengan stroke ini bisa kita berikan continuous glukosa, tetapi juga dengan monitoring yang ketat. Ya. Jangan sampai terjadi hiper maupun hipoglikemi. Ya. Ini adalah evidence base-nya, ya, cukup tinggi bahwa kita harus memaintain antara 140 sampai 180 sebetulnya. Oke. Kemudian mengenai temperatur. Ya. Untuk temperatur kita bisa suhu tubuh yang panas, ya, demam, itu akan menyebabkan outcome yang tidak baik. Sehingga perlu terapi hipotermi dengan target 35 sampai 37 derajat. Ini sebetulnya suhu normal, ya. Pada pasien dengan endovaskuler terapi, itu targetnya 35 sampai 37. Kemudian ini adalah rekomendasi untuk hipotermi. Ya. Kita harus manage pasien dengan akut ischemic stroke sebisa mungkin pada suhu antara 35 sampai 37. Ya. Kemudian untuk posisi, ya. Posisi penting karena pada posisi yang datar ini akan menyebabkan peningkatan cerebral blood flow. Nah, pada kondisi tertentu memang diperlukan, kalau tekanan intrakranial tinggi, diperlukan kondisi supaya aliran darah baliknya itu lebih cepat. Nah, tetapi pada kondisi stroke, ya, ini perlu juga aliran darah ke daerah yang mengalami iskemik, sehingga rekomendasinya justru pada pasien akut iskemik stroke ini pada posisi yang supine mendatar, bukan head up. Ya. Kemudian pemberian antikoagulan, antiplatelet, dan tromboprofilaksi, ya, ini mestinya dihindari selama 24 jam pertama setelah trombolisis. Ya. Jadi pada waktu awal-awal tetap diberikan fibrinolysis, ya, tetapi pada selanjutnya antikoagulan sampai 24 jam ini dihindari. Ya. Tapi pemberian aspirin dengan dosis 160 sampai 325 mg ini evidence base-nya adalah kelas 1. Jadi pada setelah diberikan 24 sampai 40 jam, 48 jam setelah terjadi akut iskemik stroke. Ya. Kemudian pemakaian stocking, ya, ini tidak mengurangi insidensi dari tromboemboli. Jadi boleh dipakai, boleh tidak, nah, walaupun ya rekomendasinya masih lemah, ya. Tetapi pemakaian low molecule heparin ini klasifikasinya kelas 1, ya, bukti evidence base-nya cukup tinggi, sehingga rekomendasinya adalah pemakaian low molecule heparin. Ya, ini adalah antikoagulan rekomendasinya seperti yang diberikan tadi, ya. Dan yang berikutnya adalah mengenai pengelolaan perdarahan, ya. Tidak ada guideline yang menyebutkan untuk manajemen perdarahan ini, ya, bisa, walaupun kalau memang ada perdarahan bisa digunakan fresh frozen plasma maupun recombinant faktor ke-7, ya. Ini kalau misalnya ada perdarahan, pemberian RTPA mestinya di stop sesegera mungkin. Ya. Nah, untuk pengelolaan kejang, ya, kejang harus diterapi dengan baik dan agresif, ya. Jadi pasien tidak boleh tidak boleh kejang yang terlalu sering, sehingga memang kalau ada kejang harus ditreatment, ya. Tetapi aturan untuk pemberian antikonvulsan profilaksis ini belum ada rekomendasi yang baik. Jadi sebetulnya tidak direkomendasikan untuk profilaksi, hanya saja kalau terjadi kejang harus ditreatment. Oke, ini pemberian anti kejangnya, ya. Kemudian untuk neuromonitoring, ya. Neuromonitoring ini harus kita lakukan dengan ketat, ya, karena ini berhubungan dengan outcome. Ya. Semua treatment yang kita lakukan harus kita monitor dengan baik, sehingga hasilnya bisa kita evaluasi. Ya, sebagai akhir dari presentasi kami, ya, bahwa stroke ini merupakan problem global, ya, dan dengan mortalitas dan morbiditas yang cukup tinggi. Nah, 70-80% dari stroke yang terjadi adalah stroke iskemik, ya. Hanya sedikit yang stroke hemorrhagic, walaupun angka kematiannya cukup tinggi. Untuk manajemen dari akut iskemik stroke ini perlu perawatan intensif, ya, dengan pengawasan yang ketat, kemudian manajemen yang tepat untuk pengelolaan oksigenasi, pengelolaan tekanan darah, temperatur, serum gula, dan sebagainya. Dan tentunya kita mengacu pada guideline yang saat ini sudah ada, acuannya adalah dari AHA. Ya. Guideline yang terbaru adalah guideline tahun 2021 yang terbit barusan. Ya. Terima kasih. Saya akhiri. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Sudadi, for the excellent presentation. The next speaker is Dr. Chong Chin Tet. Dr. Chong Chin-tet is a senior consultant and neuroanesthesia service head on the Department of Anesthesiology, Intensive Care, and Pain Management at Tan Tock Seng Hospital, National Healthcare, Singapore. His subspecialty interest is neuroanesthesia and neurocritical care. The title of the topic is Emergency Management of Acute Intracerebral Hemorrhage. To Dr. Chin-tet, the time is yours.
Okay, thank you, Chairperson. Thank you, everyone. I would like to just say thank you once again to the organizing committee and Professor Tatang Bisri for the kind invitation. We have met already yesterday, so I shall go straight ahead to my lecture today. Please give me some time as I share the screen. Thank you. Okay, can everyone see?
Not yet.
Can you see my slide?
Not yet.
Are you able to see my slide?
Not yet.
Not yet, okay. Okay, are you able to see my slide?
Yeah.
Hello?
Okay.
Can see? Okay, I shall begin. So my talk today is on emergency management of intracerebral hemorrhage. I shall abbreviate it with the word ICH. So I will be specifically concentrating on spontaneous, meaning non-traumatic bleeding into the parenchyma of the brain. Intracerebral hemorrhage or ICH causes 10 to 15% of the first time ever stroke in patient, and it carries a mortality rate of 35 to 50%. And if patient pass away, usually it will occur in the first 2 days. So what are the frequent causes? First cause on the list is chronic poorly controlled hypertension. It accounts for 60% of cases of ICH. Next would be due to age-related cerebroid amyloid angiopathy. Next will be due to patient having coagulopathy due to medications, for example, warfarin, antiplatelet medication. Lower down the list would be due to, for example, vascular abnormality like AVM or cavernous malformation. And then even lower down the list would be due to sympathomimetic drugs like cocaine or drug abuse with amphetamine. So these are the frequent causes of intracerebral hemorrhage. So this is a classical picture of a CT scan non-contrast of a patient with intracerebral hemorrhage. The patient actually has got chronic poorly controlled hypertension, resulting in a deep nuclear bleed in the right basal ganglia. There is also intraventricular hemorrhage as seen by the presence of blood in the ventricular system. So I would like to show you what is the approach to emergency management of ICH. And I would like to take reference from the Neurocritical Care Society using their ENLS, which is the Emergency Life Support Treatment algorithm for ICH. So as you can see on the slide, we have a flow chart which first begins with the suspicion of intracerebral hemorrhage. In the emergency treatment, if the patient has got airway compromise, okay, then or alternatively phrasing it as an inadequate airway, then you may have to secure the airway through a rapid sequence intubation. If the airway is pretty adequate, then you can go ahead and send the patient or transfer the patient for a CT brain or CT head emergently. You can use a non-contrast scan, which should be performed quite quickly within like 5 to 10 minutes. In the non-contrast CT head, if you don't detect any fresh bleeding, then you have to do assessment for possible causes of other drop in GCS or focal neurologic deficit. Some of the other causes that will be frequently picked up will be acute ischemic stroke or coma due to other medical causes. And then you will institute the appropriate ENLS protocol. But for today, let us focus on ICH. If the non-contrast CTH shows or diagnose ICH, then you want to do the following stepwise management straight away. One is quickly get a brief medical and medication history. Two is you want to control the blood pressure, bring the systolic to 140 to 180 millimeters of mercury quickly. Thirdly, you want to secure hemostasis via pharmacological means, especially if the patient is on concomitant anticoagulant or antiplatelet medication. Fourthly, you may want to consider referring to the neurosurgeon ASAP as soon as possible, which will then decide for the consideration of emergency neurosurgery depending on various criteria. Okay, and the various surgery could also include EVD other than surgical evacuation of the ICH. After that is done, then you may want to do certain prognostication or determination of the severity so as to be able to communicate the risk or the likelihood of good or poor outcome to the patient. And if you first receive this patient in a non-neuro care center, then you may want to transfer to a neuro care center. For example, to the acute tertiary care center in the urban center, or even to, let's say, to the regional center for acute neurocritical care. So again, just want to go through the checklist of ENLS. Okay, this is the checklist in the first hour, which is the golden hour. Other management strategies can also be obtained from the Critical Care Society in the United States. This is a very good review of the critical care management of spontaneous intracranial hemorrhage, a contemporary review found in the journal Neurocritical Care. Their management largely follows what is promulgated by the ENLS of the Neurocritical Care Society. So firstly, as seen on this table, they advocate the medical stabilization of the patient and then emergent prevention of hematoma expansion. Because if there is hematoma expansion, then the prognosis becomes poor. All right, so how do they advocate stabilization? As per ENLS, it will be via ABC stabilization, airway, breathing, circulation stabilization, and then quickly establishment of vital signs monitoring. And then you do a quick history of the patient and you send off for emergency lab investigation. Primarily, you want to check the platelet count and the PT-PTT INR of the patient. And then how to prevent hematoma expansion. So very aggressive or rather very quick tight pressure management. Okay, try to bring it down to 140 to 160, and then correction of any coagulopathy using pharmacological antidotes or reversal agent. Then after that is stabilized, then of course, you would have already done your CT scan to see how or where the location of the intracerebral hemorrhage is, and then refer to neurosurgeon for surgical intervention. It depends on the criteria, such as where is the location of the ICH. Is it infratentorial or supratentorial? And then After that, send the patient to the Neuro ICU for prevention of secondary brain injury, which I will talk about later. So I will give you an example of the first case. So a first case is a 78-year-old man with hypertension, atrial fibrillation, for which he is possibly on an oral anticoagulation, and then mild dementia. At 8 a.m., he has a sudden onset of slurred speech and one-sided weakness, and he was then sent by ambulance to the emergency department of acute stroke center. So this patient is quite lucky because he lives in the city, so he has availability to go to the acute stroke center. So when he arrived in the acute stroke center in less than 1 hour at 8:50 a.m., he was found to have a GCS score of 13, and the blood pressure is 172/85. So there we want to talk about the golden hour. So what should the doctor in the emergency department do for this patient in the first golden hour? I mentioned already, make sure that there is no compromise to the airway and the breathing. If there's any airway compromise, then you have to do rapid sequence intubation. Then we want to prevent hematoma expansion by good blood pressure control and by reversing any coagulopathy. Of course, you also want to prevent secondary brain injury such as systemic hypotension, hypoxemia, hypercarbia, any seizure, any fever, hyper and hypoglycemia as shown on the picture in this slide. All right, if let's say you have a suspicion of intracerebral hemorrhage and airway is adequate, then as per the ENLS protocol, you want to go straight for the CT brain non-contrast, which should be done in the next 5 to 10 minutes. And this is a picture of the patient that I talked about. So a CT brain non-contrast showed a left anterotemporal hematoma. So this is the cause of the patient altered mental state, as well as slurring of speech and one-sided weakness. Of course, I mentioned you have to quickly take a brief medication history, focusing on hypertension, atrial fibrillation, for which this patient is confirmed to be on warfarin, and then any heart disease and also social history. And then because this patient blood pressure is 172/85, so far it's still okay. The blood pressure is still within the target range of 140/80. If the blood pressure is like 200 systolic, then you want to start some labetalol infusion or nicardipine infusion, because these two drugs, they have characteristics of rapid control via rapid onset and easy titratability. Try to avoid vasodilators such as nitroprusside or GTN. So what is the principle behind blood pressure control? This is because good blood pressure control constitute one area which can be optimized for patients who present with ICH like this patient. So the initial early blood pressure control will prevent hematoma expansion within the first few hours of presentation. The risk of hematoma expansion, of course, must be balanced against the risk of inducing cerebral ischemia in the edematous region that surround the hemorrhage, meaning the penumbra. The role of aggressive blood control is first suggested by the INTERACT-2 study, which stated that within 6 hours of the onset of hemorrhage, they want to target the systolic blood pressure to hopefully 140 mmHg. This is deemed to be safe and is able to reduce hematoma growth. Later on, the ATTACK-2 trial comparing two groups of blood pressure control between 110 to 130 in the first group versus 140 to 170 in the second group. And it shows that there is no difference in death or disability. So in conclusion, they view that trying to achieve a SBP 140 is pretty safe. Okay, but if excessive lowering, such as less than 130, it may lead to increase in a renal complication without any improvement in death or disability. So overall, in conclusion, yes, you may want to aim a blood pressure 140 mmHg, but not less than that. No need to overcorrect to less than 130. So in reality, usually in the ICU, we will be quite happy to keep SBP within 140 to 180. Okay, this is the Tan Tock Seng protocol, which was formulated by our Neuro ICU director, Dr. Wong, with the consultation with the neurosurgeon. So what they recommend is, firstly, if the blood pressure more than 200 systolic or MAP more than 150, then you want to try to achieve a BP, quickly lower it to range of 180 to 200 in the first instance. And then later on, when the patient is more stable and there is no suspicion of elevated ICP, then you can aim to target BP about 140 to 190. Usually that would be in the range that we can achieve realistically would be systolic 140 to 160. Although, as I mentioned in the INTERACT trial, they feel that 140 to 180 is also quite acceptable. So after that, consider acute pharmacological antidotes to reverse any coagulopathy. So this patient was on warfarin for atrial fibrillation and the patient INR is 3.5. So we have to give some antidote to reverse the anticoagulant. And the warfarin coagulopathy reversal is dependent on what is the patient presenting INR and what is the patient body weight. So in Tan Tock Seng Hospital, we use the 4-factor PCC, which is the prothrombin complex concentrate. And the 4-factor PCC is the octaplex. So the dosing is dependent on the patient weight and what is the INR. So we will prefer PCC over FFP because PCC can be given very quickly. We don't have to wait for any delay due to the blood bank. And also PCC can be given rapidly in almost like quick bolus within 5 to 10 minutes, rather than FFP, which have to give over 2 to 4 hours. So PCC definitely is advantageous in terms of reversing the coagulopathy emergently. Next, we want to dose the patient with vitamin K 10 mg for sustained reversal because PCC, although it is rapid onset, it has quite a short half-life. So for sustained reversal over the next 24 to 48 hours, you want to give vitamin K IV. If the patient has got other coagulopathy or other antiplatelet medication on board, then this table shows the reversal agent. Okay. Next, we refer to neurosurgeon for consideration of surgery. For example, in supratentorial ICH, if there's mass effect, then you want to also consider emergency suite neurosurgery. If there is intraventricular extension of the hematoma, you want to consider emergency EVD to relieve the hydrocephalus due to the intraventricular hemorrhage, especially if the GCS is less than 8. Okay, so I want to show you some picture. So this patient has got acute spot sign, which means active contrast extravasation, which means acute that the acute bleeding is still ongoing. Okay, I just want to show some picture also of how to get so-called assessment of the ICH. Okay, this can provide some limited or rather some information or prognostication of the case, but mainly it is to communicate the risk or the likelihood of favorable versus unfavorable outcome in patient. So you can determine this based on the ICH score, which is partly determined by the volume of the bleeding, which the neuroradiologist can calculate for us. Okay, and then it will also give the ICH score can also be determined by the location of the bleeding. Okay, so for example, the GCS score in this patient that I presented, the GCS score is 13, so score point is 0. The ICH volume as determined by the radiologist is less than 30, score 0, but he has presence of intraventricular hemorrhage, so score 0.1. And because this patient has a supratentorial bleed, so it is not infratentorial, so score 0. And the age is 70 something, so score 0. So the ICH score is only 1. So most likely you can say the patient would likely, when you communicate to the family, that should have quite good outcome in the end. So I think therefore the ICH score, it is ways to see whether what is the increase in the risk of mortality versus the likelihood of good functional outcome. And it's a good method to communicate disease severity to the family members. After that, if you happen to take care of this patient in, let's say, in a rural hospital or in a non-stroke center, then you want to arrange for transfer for neurocritical care management in the acute stroke center, transfer to the urban center or to the acute tertiary hospital or to the neurocritical care center after stabilization. So another case history would be a 56-year-old lady, sudden vomiting, headache, and slurred speech at 5:30 p.m. GCS is 15. The patient is not on warfarin, but is on aspirin for ischemic heart disease. So as per the first case, please do all the acute assessment, including medical history, and then arrange for acute non-contrast CTH. This patient is shown to have a infratentorial bleed in the right cerebellum. After the scan is done, again, make an ongoing assessment of the patient's adequate airway patency. If patient drop GCS, then you may have to intubate the patient. Again, aim for blood pressure 140 to 180. This patient blood pressure very high, systolic 230. So quickly start IV labetalol or start nicardipine. And then this patient, INR, of course, is normal because not on warfarin, not on anticoagulant. But bear in mind, the patient is on antiplatelet medication, aspirin. So you may want to consider platelet therapy. Okay, but this platelet therapy is depend on the situation and also depending on whether the patient going for emergency surgery. Okay, or whether or not to give platelet transfusion. Then you want to consider emergency surgery in this infratentorial bleed, but refer to the neurosurgeon for the decision. Okay, and then you can also do ICH scoring, and depending on the ICH scoring, you can give a likelihood of good outcome or poor outcome to the family member via communication. Okay, so I want to show what some of the neurosurgeon can do for emergency neurosurgery for ICH after referring to the neurosurgeon. So you can see in this picture in slide A, the patient has got a deep nuclear bleed, most likely hypertensive BG bleed. All right, so usually conventional craniectomy, there is quite a lot of collateral damage during surgery, and post-op, a lot of hematoma and swelling still. Okay, in this patient, the patient underwent conventional craniectomy and evacuation of the hematoma. Day 2 after the surgery, okay, there is some residual blood still, but more or less the mass effect is removed, there is, I would say, okay, adequate evacuation of the hematoma, but you can see that there is usually quite a lot of collateral edema or damage from the neurosurgery. And even 4 weeks after neurosurgery, there is quite a lot of swelling still, okay? And there is a bit of brain protrusion through the craniectomy, through the bone flap still. So in Tan Tock Seng Hospital, recently we used the minimally invasive evacuation of the intracerebral hematoma via brain path. I will show you some picture of that. So compared to conventional craniectomy, the MIS surgery for intracerebral hematoma evacuation will minimize collateral brain damage, and the hematoma can be quite well evacuated, as shown on the lower row of pictures compared to the upper row. And after 4 weeks, the swelling is much less compared to the conventional craniectomy. But most importantly, the minimally invasive evacuation allowed the bone flap to be placed at the point of surgery. Okay, because usually the surrounding hematoma and collateral damage is less. So you can see in the lower row, the patient has got the bone flap replaced at the first point of surgery. Okay, so don't have to go for cranioplasty 4 weeks or 3 months after evacuation of the acute hematoma. Okay, and because it's minimally invasive, the collateral damage is much less, as shown on the last picture. So this is what MIS, minimally invasive surgery, neurosurgery, is performed by some of the neurosurgeons in Tan Tock Seng Hospital. Okay, they will do neuronavigation, then instead of a wide craniectomy, they can do a limited craniectomy because they can precisely locate the site of the hematoma, and then they will put in an endoscope and they will do aspiration of the hematoma. Okay, as this picture shows, there is minimal collateral brain swelling, and you can do a limited craniectomy, or you can even put back the bone flap. Okay, so therefore, in conclusion, what are some of the clinical pearls that I would like to share today? So bear in mind that hematoma expansion can occur in the first few hours and up to 40% in the first 6 to 12 hours. So if the patient airway is secure, or if the patient airway is adequate, then you want to do a non-contrast CT scan ASAP. If there is any spot sign, that it may indicate that there is ongoing bleeding still. So these patients with a spot sign would be at risk of hematoma expansion. And you then have to aggressively try to control the blood pressure. Okay, ICH, I would say, is used as a communication tool, but I wouldn't really say definitively this is a predictor for neurologic outcome, because there are various other events that can predict overall neurologic outcome. For example, the ICU care and whether the patient developed other medical sequelae of a prolonged bed rest and immobility, such as infection or pneumonia or deep vein thrombosis. But it is useful as a communication tool to communicate with the family the likelihood of a neurosurgical good outcome versus poor outcome, but it's not a definite predictor. Then it is best that the patient is taken care of in a neurocritical care unit or an acute stroke unit. Try to, after stabilization, you can transfer to the acute tertiary care center with a neuro ICU if possible, because it is shown to improve ICH outcome. The lower the blood pressure target to 140 to 180, but how specific or aggressive you have to base on the patient-related risk factor. For example, whether the patient has got a renal disease or ischemic heart disease, that may contraindicate too aggressive lowering. So I would say, therefore, you can start some IV medication like labetalol or nicardipine. You can lower to 140 to 180. No need to normalize it to 120 because it is not associated with improved outcome less than 140, but in fact it's associated with more renal side effects. So 140, 180 seems to be pretty sufficient. Then urgent coagulopathy reversal through the pharmacological antidotes to minimize hematoma expansion. And if there is seizure, treat seizure as part of the minimization of secondary brain injury. Okay, if no seizure, then no need routine seizure prophylaxis. Okay, so thank you so much. I can take some questions at the end. Thank you.
Yeah, thank you, Dr. Chintat, for the excellent presentation. The next presentation will be presented by Dr. Leong Kok Weng with the title of Cerebral Hypoperfusion Syndrome. Dr. Leong currently employment is Department of Anesthesiology and Intensive Care Hospital, Kuala Lumpur. Fellowship in neuroanesthesia was from Toronto Western Hospital, Faculty of Medicine, University of Toronto in 2020. To Dr. Leong Kok Weng, the time is yours.
Okay, thank you. So I'm just going to share my screen. Okay, can you all see my screen?
Okay, good.
All right. Okay. Thank you for the kind introduction. It is my pleasure to speak again in the Neuro ICU Symposium, and the topic given to me is cerebral hyperperfusion syndrome, which is actually a very rare but potentially devastating complication. So without further ado, okay, I have no conflict of interest to disclose. All right, okay, so cerebral revascularization procedure is actually life-saving, right? So, so there are many randomized control trials done in the past 30 or 40 years, which shows the efficacy of revascularization to prevent stroke. So like, but in the past 10 years or so, there's this concept is actually being challenged because there are actually more and more aggressive medical therapy, right? But despite that, revascularization still remains a class 1 recommendation in AHA guideline published last year. Right, so just as a high-level recap, in carotid end arterectomy, it's just basically where the clot is being removed, followed by a closure. And for carotid artery angioplasty or stenting, basically a catheter will go through the site of occlusion, followed by an angioplasty and followed by a stent. And okay, so and in this ECIC bypass basically is just the STA, which is an extracranial vessels, is anastomosed to the MCA. Right. So basically, after carotid end arterectomy, the flow restoration is almost immediate, right? So depending on the degree of occlusion, the flow augmentation can go up to 12 times compared to the previous baseline. And actually, a quite significant amount of the patient actually has flow augmentation about 200 times, which is a twofold increase. Right, so this group of patients are the one that we label them as having a hyperperfused brain. So this flow restoration actually occurs immediately post-op, maximum at day 3 to 4, and go on to a new steady state by day 6 or 7. Okay, for carotid artery angioplasty and stenting is more or less the same. So the magnitude of improvement is about 50 to 60%. And for ECIC bypass is in the vicinity of about 20 to 30%, okay, or 50 mils per minute. So so theoretically it'd be good, right? I mean, if we perfuse the brain, then we restore the flow. I mean, it's definitely going to be good, right, for patient's outcome, but not necessarily so, right? So of about 100 patients that undergo cerebral revascularization, about 10 to 20% of them actually have a hyperperfused brain, right? So, but out of this hyperperfused brain, a small amount of them go on to develop some amount of features suggestive of cerebral edema or intracranial hemorrhage. But good thing, the majority of the patient with hyperperfusion don't have this syndrome, right? Okay, so like those patient that has a hyperperfused brain and then develop cerebral edema and intracranial hemorrhage is the one that we label as cerebral hyperperfusion syndrome, right? So incidence is actually pretty rare, depending on the studies that is that's reported in literature. It stays about 0.7 to 6.7%, but the general figure seems to be about 1% or so. So there's actually different time frame where this clinical entity happens. In carotid artery stenting, actually generally faster, right? 12 hours. And as compared to carotid end arterectomy, which tend to develop a bit later. And the risk for hyperperfusion syndrome persists up to a month, right? So what are the clinical presentations? So depending on the case series, but generally the commonest symptom is deterioration in consciousness, right? Followed by ipsilateral headache, seizure, hemiparesis, and the other signs and symptoms are aphasia and hemorrhage. Okay, so like the meta-analysis done by Moulakakis in 2009 actually state the incidence for hemorrhage of about 4.8%, but I tend to think that this figure is actually hyperinflated. I mean, these are inflated. Other studies seem to show that an incidence about 1 to 2%. Okay, so in the report by Sun in 1981, okay, so by the way, he's the first person who reported this syndrome, right? So he actually reported a triad of a headache, seizure, and focal neurological deficit, right? And Buri, in his meta-analysis, actually narrowed down the criteria into 4. So basically, it must occur within 30 days of carotid end arterectomy. Okay, so there's evidence of a hyperperfusion, or when there's hypertension, systolic blood pressure more equal 180 millimeters mercury. There's clinical features suggestive of cerebral edema and or hemorrhage, and other causes are being ruled out. For example, stroke, re-occlusion, and pharmacological or metabolic causes. So there are various pathophysiology theory that's being reported. All right. So like the one that's commonly accepted is impaired autoregulation theory. So basically, this is more or less the same as this normal perfusion pressure breakthrough in AVM resection, right? So basically, due to chronic hypoperfusion or chronic ischemia, so like the vessels there are maximally vasodilated. So after a prolonged vasodilation, then it becomes vasoplegic. So like a vasoplegic arterioles is actually not good, right? As in when there's sudden restoration of flow, it won't be able to constrict at all to limit the flow. Or in other words, there's loss of cerebral autoregulation. So as a result, when blood pressure increases, the cerebral blood volume also increases, and the transmural pressure, the driving pressure to drive fluids into the brain is also higher. Right, and the other theory is endothelial injury theory. Okay, so like basically, in an ischemic brain, free radical species are being released, and And what these free radical species tend to do is to increase this endothelium permeability as well as vasodilation, right? So after you restore the flow, what happens? There's transfer of fluid from the intravascular space into the cerebral parenchyma and leads to vasogenic edema. And this baroreceptor denervation theory is basically this effect tend to augment the impaired autoregulation as well as endothelial injury. So basically, during carotid end arterectomy as well as carotid stenting, there's basically some amount of injury to your baroreceptor, right? So as a result, there's actually loss of ability of your baroreceptor to control blood pressure, and as a result, there's always hypertension after the carotid end arterectomy or stenting, and hypertension is the one that sort of worsen this cerebral hyperperfusion. Okay, so like I reported earlier that carotid artery stenting versus carotid end arterectomy, cerebral hyperperfusion tend to happen a bit earlier in carotid stenting, right? So the real reason for this is actually unknown, but various theories has been put forth to again try to rationalize what happened. So basically, in carotid artery stenting, we tend to reserve a sicker patient to carotid artery stenting. Okay, so this is a theory put forth by Smolakakis, right? So the other theory is this sort of patients tend to have more aggressive anticoagulation due to an indwelling stent, right? And this Gallifoss in 2017 put forth this baroreceptor theory. Okay, so basically during deployment of this balloon or deployment of stent, that's basically stretch of the baroreceptor, right? So this causes hypotension and also bradycardia just as a result of a stretch in your baroreceptor. So after we remove that stretch, there's going to be some amount of rebound hypertension, and this rebound hypertension is what that sort of worsen that cerebral hyperperfusion. And the plaque embolization theory is proposed by a group of Japan neurosurgeon. So basically, what they propose is that during angioplasty, there's embolization of plaque, which causes distal ischemia, right? So after recanalization, so like it sort of worsens that hyperperfusion. So as compared to carotid artery stenting and carotid end arterectomy, the incidence seems to be higher for carotid end arterectomy. Okay, with odds ratio of about 1.4. So but if you look at the meta-analysis that was done by Gallifoss in 2017, those patients that undergo carotid end arterectomy tend to be from earlier studies, right, where blood pressure management, the medical treatment might not be that mature yet. So like the true incidence of hyperperfusion syndrome in carotid end arterectomy versus stenting is still unsure. Okay. So then what about hemorrhage? So tend to be higher in carotid artery stenting, okay, just because they are more aggressively anticoagulated. And as a result, there's higher risk of bleeding. Okay, so risk factors for cerebral hyperperfusion syndrome, okay, diabetic mellitus, or chronic hypertension, which actually link to a hypertensive microangiopathy. Those have a previous stroke or recent stroke less than 2 weeks. Those who are elderly, those has contralateral carotid end arterectomy within 3 months, and also high-grade carotid artery stenosis more equal 70%. So the risk factor for the flow-rated risk factor for cerebral hyperperfusion, like the poor collaterals, okay, as defined as collateral occlusion of more than 80%. There's impaired circle of Willis. There's a carotid artery stump pressure of less than 40 mm², which is an indicator of poor collaterals, right? And impaired cerebral vascular reactivity. And the most important modifiable perioperative factor is blood pressure. So hypertension has been consistently related to cerebral hyperperfusion syndrome, right? So in the meta-analysis that Bori, so like based on the table here, it shows that when blood pressure more than 150, systolic blood pressure is more than 150 millimeter mercury, the incidence of hyperperfusion tend to increase, right? And there's basically no hyperperfusion when the systolic blood pressure is less than 140 millimeter mercury, right? So this forms the basis of preventative as well as treatment for cerebral hyperperfusion. Then what about inhalation? What about the choice of anesthetic? Okay, so the inhalation agent has been shown to be related to cerebral hyperperfusion in only one study, right? So the theory put forth is because of the worst cerebral vasodilation, okay, induced by inhalation agent, right? Especially when the MAC is too high for that particular group of patients. So this is a study in Spain back in 2019, which tried to circle up the risk factor for cerebral hyperperfusion after carotid artery stenting. So after analysis, it shows that 4 risk factors are associated with cerebral hyperperfusion. Okay, elderly patient, female, renal failure, and very interestingly, left carotid stenting. Okay, so like basically, there are reasons why left-sided are more affected than the right side, right? It's based on the anatomy, because like if you look at the anatomy for the carotid arteries left and right, so the left side it come up immediately out of from this out of aorta, right, as compared to right side, which goes through brachiocephalic artery and then branches out. So there's actually some evidence that left-sided carotid actually exposed to more flow stress, and as a result, there's more risk of hyperperfusion. Right. So how do you work up or to diagnose a patient with hyperperfusion syndrome? Okay, so basically we have to prove 2 things. There's evidence of hyperperfusion, and there's features of cerebral edema or intracranial hemorrhage. So there are various modalities we can use. The one that's very popular is transcranial Doppler and our SPECT. So basically, in transcranial Doppler, basically what we are looking at is the middle cerebral artery velocity, okay, which is a surrogate for flow, right? So so like in this case report, it shows that the flow in MCA actually doubles after carotid artery stenting, and this patient actually developed cerebral hyperperfusion syndrome, right? So the good thing about transcranial Doppler is that it's actually a bedside test. It's readily available, and we can actually repeat it like every 6 hours or 4 hours just to monitor the flow, and it can be used as the monitoring device, right? To see whether is the blood pressure lowering adequate for that patient, right? So that's transcranial Doppler, and the other very popular imaging modalities is SPECT. Okay, so basically it's a nuclear imaging where the radioisotope is being administered, and what they are looking at here is the flow to the different regions of the brain, right? So if you look at the first picture on the left side, the right hemisphere tends to be blue, right? Okay, so this is a feature that this is a hypoperfused brain as compared to the left side, which is pretty much normal. So this is a pre-op scan of the patient, okay, the left side one, and the middle one, the middle image is the SPECT, which is done immediately post-op, which shows there's actually increased flow, right, to the right side, which is the affected side, while the normal side, the ipsilateral side, tend to be like more or less the same, just although it's slightly increased, right? And actually 4 days down the line, the hyperperfusion over the right side actually get worse. Okay, it was so red and it was so hyperperfused. Right, so this is a very good imaging modality for us to diagnose hyperperfusion, right? So other modalities that we can use is like perfusion MRI and also like the normal CT or MRI just to look at cerebral edema and hemorrhage. So like there are actually ways to predict whether a patient will or will not develop cerebral hyperperfusion syndrome, right? So one of the very good tests is looking at cerebrovascular reactivity. So basically in the picture here, the left top one is the pre-op SPECT. I mean, like as in before acetazolamide challenge, right? And the lower one, you see that like although after acetazolamide there's no increase in flow, because we know that acetazolamide sort of increases cerebral blood flow, right, by the action of carbon dioxide. So there's basically no improvement in flow, like although the CO2 has been increased in the plasma. So this is a patient that has very impaired cerebrovascular reactivity. And true enough, after carotid end atherectomy, the middle image there's increase in cerebral blood flow to the same side of the brain, of the operative side. And 3 days after that, it got worse, right? So like this is actually a very good predicting tool to predict whether a patient will develop hyperperfusion or not. Okay, so like blood pressure management, the most important one is early recognition and aggressive blood pressure treatment. Okay, so again, all patients needs to be monitored in the high dependency unit. Okay, depending on the institution, it can be in the ICU or it can be in the HCW. So the blood pressure target should be jointly discussed within all key players. Okay, so like neurologists, neurosurgeon, neurointensivist, neuroanesthetists, all should come together and discuss the proper blood pressure goal. So like one of the other tenet is how much blood pressure that we should aim for, right? So like again, every patient is different. Some of the centers tend to agree with blood pressure about 140/90, right? And again, this target should be guided by clinical examination as well as cerebral blood flow studies, okay, using transcranial Doppler or SPECT. So what about choice of antihypertensive? As of now, still no consensus, but we sort of agree that the first line should always be labetalol, right? Just that because we are so familiar with it, right? And because there's no increase in cerebral blood flow after labetalol. Okay. There's no role for prophylactic diuretics or anti-epileptics, okay, unless patient has seizure, unless patient has cerebral edema, right? And there's no role for free radical scavenger, okay, like Radicat, which is available in Japan. Basically, this is a free radical scavenger that mops up all the free radicals. So, but again, how long do we have to lower the blood pressure? Again, this is very difficult for us to decide because like every patient is different, right? So what is the downfall of the blood pressure therapy? Okay, so again, as I said, one size doesn't fit all. Okay, so one blood pressure target doesn't fit all patients. All right. Okay, so the blood pressure management should be individualized. And the other thing is hemodynamic swing occurs in as many as 66% of the patient. Okay, so it can be because of post-induction. It can be because of after we dilated that carotid sinus and you stretch the baroreceptor, or it can be because of emergence phenomena when patient wake up from the anesthetic. Okay, so hemodynamic swing tend to be severe in 20% of them, right? Okay, so the risk factor of hyperperfusion syndrome is hypertension, and is sometimes very difficult to control in the perioperative setting, right? And the third downfall is what about patient has contralateral disease? So like lowering blood pressure too much may actually reduce perfusion to that side of the brain. Okay, so which can be counterproductive. And the last downfall is how long to risk mitigate, right? Okay, so some center actually recommend about 1 month of aggressive blood pressure management. Okay, but I've seen reports of centers which carry on this up to 6 months, right? Just because of this complication. Okay, so prognosis of cerebral hyperperfusion syndrome is actually pretty good. Only if we detect early, we treat early, right? So 83% made the full recovery without deficits. 13% made the partial recovery with permanent deficit, and 4% of them died, right? But again, once hemorrhage happens, it is an indicator of very poor prognosis, right? Okay, once it happens, 50% of them will die, right? And 28% of them will develop permanent disability, left with about 15 to 20% of them which made the full recovery. Okay, so with that, I will summarize my talk. So basically, hyperperfusion is defined as flow increase of more than 100%, right? Okay, which occurs in 10 to 20% of patients, but only about 1% of them develop cerebral hyperperfusion syndrome. Okay, it tends to occur a bit earlier in carotid artery stenting as compared to carotid end atherectomy. And so 3 theories have been put forth: autoregulation, impaired autoregulation theory, endothelial injury theory, as well as baroreceptor disruption. And the commonest presentation for cerebral hyperperfusion is as this altered conscious level, headache, seizure, and hemiparesis. Okay, so this is collaborated with evidence of hyperperfusion from transcranial Doppler or SPECT. So postoperative hypertension is the single most modifiable risk factor for hyperperfusion syndrome, and the key to successful management is aggressive detection and management of blood pressure. Okay, guided by flow studies. And the prognosis is actually quite good unless cerebral hemorrhage happens, of which carries a mortality of about 50%. Okay, so with that, I end my talk. Okay, thank you very much.
Okay. Thank you, Dr. Leong, for the nice presentation. Okay, ladies and gentlemen, the last presentation will be presented by Dr. Putu Pramana Swarjaya with the title of Management of Cerebral Venous Thrombosis. Dr. Pramana is from Department of Anesthesiology and Intensive Therapy, Udayana University Denpasar. Degree from Neuro Anesthesia and Critical Care Consultant obtained from Pajajaran University in 2012. Ladies and gentlemen, please welcome Mr. Putu Pramana Swarjaya.
Thank you very much, Dr. Himawan, for your kind introduction. It is a big honor for me being invited in this second Biennial Neuro ICU Symposium, and congratulations to Dr. Kenanga and the Department of Anesthesia, RSUD Ulin, Medical Faculty of University Lambung Mangkurat, with successfully organized this well-organized meeting. And please give me some time to share the screen. Can you see my screen, Doctor?
Yes, okay. Please continue.
Thank you very much. Good morning, everybody. This morning I have the talk about management of cerebral venous thrombosis. This cerebral venous thrombosis has been regarded as a rare cause of stroke with a good overall prognosis. Even a small number will be also could be deleterious. So the rarity of this disease, this cerebral venous thrombosis, has made it difficult to study in clinical trial because this is quite rare. So current treatment and guidelines are mostly consensus based. Cerebral venous thrombosis is caused by a complete or partial occlusion of the cerebral major cerebral venous sinus. It's called cerebral venous sinus thrombosis, or the smaller feeding cortical vein or cortical vein thrombosis. This is an important cause of stroke in young adult. This is maybe in the talk before we discuss about stroke. This is rare and mostly happen in young adults. From this phenogram, we'll see the location of the cerebral venous and sinus thrombosis. We see mostly occur in superior sagittal sinus. And the second place is the transverse or lateral sinus. And the third most common is in the stride sinus. And also we see other part of the sinus and venous can be the location of this thrombosis. The pathophysiology of the cerebral venous thrombosis. The thrombosis of cerebral veins can increase the venular and capillary pressure, and the thrombosis of cerebral venous sinus can decrease the CSF absorption. Both of these will increase the intracranial pressure, and which promote cytotoxic and vasogenic edema. And in the later state, there will be a disruption of blood-brain barrier with could be progress to hemorrhagic hemorrhagic infarction. This cerebral venous thrombosis can be provoked or unprovoked or spontaneous. And there's some risk factors, and multiple risk factors can coexist in individual patient. I'll show you some risk factors for this cerebral venous thrombosis. For example, thrombophilia, genetic or acquired, infection, intracranial or infection in the head, in the nose, or systemic infection could be the risk factor. A trauma also, head injury, cranial surgery, also reproductive this if in pregnancy and puerperium period, if we have some kind of stroke, please we should think about consider about cerebral venous thrombosis. Also malignancy, intracranial or extracranial. Some medication also be a risk factor for the CVT. For example, oral contraceptive, steroid use, anti-neoplastic drug, or inflammatory condition like vasculitis from Behçet disease or SLE, or hematologic, endocrine, systemic dehydration, sepsis also can be the risk factor. Also intracranial abnormalities like dural fistula or AVM and other venous abnormalities can increase the risk for cerebral venous thrombosis. The clinical presentation of this cerebral venous thrombosis is very dependent on thrombus location and the extent of the rise intracranial pressure, and whether it is related to venous pressure alone or already there is an extensive parenchymal damage. And the most patient is present with headache. So headache present in 90% of cases. In 25% of patients, headache is the only symptom report. This is the clinical presentation of the CVT. So we see a headache present in 75% of the cases. The next most common clinical symptom is papillary edema, seizures, motor or sensory deficit, mental status change, dysphasia, and also cranial nerve palsy, cerebral incoordination, or bilateral or alternating cortical sign, nystagmus, even hearing loss. This is a neurologic examination that can perform to diagnose this disease. An enhanced CT is valuable for screening patients with non-specific clinical presentation and low suspicion of CVD, because this is progress quite slow, and we are not easy to distinguish from other form of stroke. And also we can perform a contrast enhanced CT that will provide a more accurate diagnosis. And the technique of choice is the MRI or magnetic resonance phenography. But now the CT phenography is emerging, because you know in our country the magnet MRI not available in every place. Now we're moving to the therapeutic recommendation. The therapeutic recommendation consists of the antithrombotic treatment and the treatment for intracranial hypertension with follow the CVT and symptomatic treatment. Regarding antithrombotic treatment, we will look at the acute anticoagulant treatment for the CVT and type of heparin in use in acute CVT management, and how long is the duration of anticoagulation recommended. And also there's emerging concern about there's a new anticoagulant available, and what's the evidence about direct anticoagulants. And also the more aggressive intervention like thrombolysis and thrombectomy in acute CVT. There is some even quite old reference about whether anticoagulant or the study assessed the efficacy and safety of anticoagulant therapy in patients with already radiologically confirmed as cerebral venous thrombosis. This is by the Dutch group, and this study found that in CVT, anticoagulation will improve clinical outcome compared with no anticoagulant, with a risk, decreased risk to 0.97. So it favor using anticoagulant. And the next discussion is about what type of heparin we use better in acute CVT. This is also from the Dutch group that they will compare whether use unfractionated heparin or low molecular weight heparin for the treatment of cerebral venous thrombosis. This is a non-randomized prospective cohort and of around 600 patients with CVT, which primary endpoint is the functional independency at 6 months. So modified Rankin score 2 or below. We see in this diagram the upper one, the low patient treated with low molecular weight heparin has better modified Rankin score. So less patient with worse outcome compared to the unfractionated heparin in this study. So this non-randomized study suggests a better efficacy and safety of using low molecular weight heparin of unfractionated heparin, and low molecular weight heparin seem preferable over the unfractionated one. And next, how about the duration of anticoagulation? Oral anticoagulants can be given for a variable period of time, somewhere between 3 to 12 months after CVT to prevent recurrency. But for patients with already recurrent venous thrombosis or with an associated prothrombotic condition with high thrombotic risk, for example, they have a multiple risk factor, may need permanent anticoagulation. This is also a study which compared the novel oral anticoagulant and vitamin K antagonist in patients with CVT. This is a systematic review on efficacy and safety. As we know, in Indonesia, we starting to have the newer anticoagulants. Whether newer anticoagulant could replace the vitamin K antagonist in CVT treatment. In this study, which published in 2020, it consists of some RCT, but mostly observational study. They find no significant difference in recurrency rate or death between the novel oral anticoagulants and vitamin K antagonist, which is the standard therapy. And also in the full recanalization, this study found there's no significant difference between the newer oral anticoagulants than standard FIT-K antagonists regarding the full recanalization. The study also looked deeper at partial recanalization, and also they find no significant difference on partial recanalization between newer oral anticoagulants and FIT-K antagonists. This is also another study on which published just a few months ago. They compare the direct anticoagulant, the newer oral anticoagulant in treatment cerebral venous thrombosis. This is a systematic review because current guideline also we see from other study did not recommend direct oral anticoagulants to CVT despite their benefits of standard therapy. This systematic review will summarize the published experience in the direct anticoagulant therapy for CVT. This study included 33 studies, only one RCT and 5 observational cohorts, and most is case series and involving using dabigatran, rivaroxaban, apixaban, and endoxaban. In addition to 315 patients treated with standard therapy. So the study found a similar risk of death in using the newer oral anticoagulant and standard therapy. And even the new intracerebral hemorrhage in a similar manner with the standard therapy. But a favorable modified Rankin score, they found with between 0 and 2 reported better in the newer direct oral anticoagulant treated patients, more likely than standard therapy in observational cohort. So this forest plot, we see that even those they found that still favor standard therapy. This is another study on this study conclude that evidence of using direct anticoagulants in CVT is limited, although there's some suggestion about a little bit better safety and efficacy despite variability in timing and dose treatment. So we need a further rigorous trial to validate these findings. So there's almost no difference between the standard therapy and direct oral anticoagulant, especially when a cost is still an issue. How about the more aggressive treatment? In some group of patients, maybe we need there's some logic reason to try thrombolysis or thrombectomy in acute CVT. Let's see the evidence. This is a schematic review of the literature regarding the safety of thrombosis in cerebral venous thrombosis. This very simple review conclude this thrombolysis is associated with a non-negligible incident of major bleeding complication. And this intracranial bleeding potential will affect a patient outcome, so they not recommended. There's also another study about mechanical thrombectomy performed in cerebral venous thrombosis. The aim of the study is to understand the efficacy and safety of mechanical thrombectomy in CVT patients. They find 42 studies, which included 185 patients, and 60% of patients had a pretreatment intracerebral hemorrhage. This is a worse group of CVT patient, and 70% was stuporous or comatose. And they find after mechanical thrombectomy, the major peri-procedural complication was new or increased intracerebral hemorrhage until 10%. So they know we cannot recommend mechanical thrombectomy in CVT treatment. This is also increased popularity of endovascular treatment. Let's see the effect of endovascular treatment with medical management versus standard care, which only using the anticoagulants in severe cerebral venous thrombosis. This is the 2-act RCT. This RCT found this multicenter open label blinded endpoint RCT involving 67 patients. The study find no difference in degree of disability at 12 months between patients who underwent endovascular treatment with patient receiving standard care alone. So in conclusion, endovascular treatment may not improve the functional outcome of patients with CVT, and further trial may be needed to confirm this conclusion. And we move next to the treatment of other effect of CVT, further effect of CVT, which is intracranial hypertension. We should apply the general principle therapy of rise ICP, like head elevation, IV osmotic diuretic, and maybe we can, in some profound condition that very emergent, condition, we can use a temporary hyperventilation with a target PCO2 to 30 and 30 until 35. But this is only temporary measure, and so we should apply the general principles of RISE ICP. And how about the secondary therapy of treatment of this intracranial hypertension, like therapeutic lumbar puncture, acetosalamide, and diuretic steroid? Let's see the recommendation or best practice. Therapeutic LP may be considered in patient with CVT. Maybe you consider, but we should see a risk and benefit, and also whenever safety profile is acceptable. So there is no recommendation on this. And also this most of the study not recommend using acetosalamide for patient with acute CVT to prevent death or to improve functional outcome. Also, steroid is not recommended except in patient with acute CVT and systemic inflammatory disease like suffering Behçet disease or SLE. And regarding severe hydrocephalus, CVT is rarely causing severe hydrocephalus. There's some exception, maybe some cases with space occupying posterior fossa with block the ventricle outflow of GFS or intraventricular bleeding, maybe can cause severe hydrocephalus and need AVD or some aggressive treatment for hydrocephalus. And in symptomatic treatment, because most of patients present with headache and the neck seizure, is already also already mentioned in the previous session, with 40% of CVT patients may present with seizures, and this seizure 5 to 10% patient experiencing recurrent seizures in this in CVT period. Let's look at the study about early seizure in CVT. Whether we need to use prophylactic anti-epileptic in the acute phase, because the study confirmed nearly 40% of the patient with CVT have seizures, and with 5 to 10% also experiencing recurrent event after seizures within 2 weeks of diagnosis. Let's see this comparison for patient treating with anti-epileptic drug and no anti-epileptic drug, especially for patient with supratentorial lesion with presenting seizure. This anti-epileptic drug is significantly, it's very effective in prevent seizure and recurrency of seizures. So this study recommend CVT patient with supratentorial lesion especially need anti-epileptic drug. So this result support the prescription of anti-epileptic drug in acute CVT with supratentorial lesion who present with seizures. And how about surgical consideration? Because we as a neuro anesthesia will face this situation. This is when we need decompressive decompressive craniectomy. This decompressive measure may be needed as a life-saving measure if a large venous infection lead to a significant edema and significant increase in intracranial pressure. And large hematome, even rare, may be need to be considered for surgical evacuation if associated with severe and progressive neurological deficit will also imply in a worse prognosis. So this is end of my talk today. In summary, cerebral venous thrombosis is rare. Outcome is often good, but potentially life-threatening. And in this episode of life-threatening, they will involving we are as a neuroanesthesiologist or neurocritical care also to support this patient can so the better outcome can achieve. This day, anticoagulant is the current standard of care, and for patients with recurrent venous thrombosis or with a high thrombotic risk may need even a permanent anticoagulation. A more aggressive therapies with acute heroic therapies reserved for cases only where first-line anticoagulation fail. I think that's my talk for today. Thank you for your kind attention. Terima kasih banyak, Dr. Himawan.
Terima kasih, Dr. Putu. Thank you, Dr. Putu Pramana, for the excellent presentation. According to the time we have here, we only have 10 minutes to discussion. There are several questions addressed to the speaker have already answered in the chat column from Dr. Chong Chin Tet, also from Dr. Leong. Okay. This is a question from audience to answer to Dr. Sudadi. Bagaimana strategi teknik memasang NGT dengan baik pada pasien yang berada di unit stroke agar sangat safety sehingga tidak terjadi gejolak yang akan berpotensi memperberat stroke-nya? Kompetensi siapa yang melakukan? Silakan dokter. Please, ya. Dr. Sudadi, to answer.
Terima kasih dokter untuk pertanyaan ini. Jadi pada pasien stroke, apalagi dengan penurunan kesadaran, kalau PCS di bawah 9, tentu kita dengan protokol untuk menjaga airway tetap baik, kita intubasi. Nah, pada saat dilakukan intubasi, kita bisa pasang NGT. Kalau misalnya pasien GCS di atas 9 dan mungkin tidak kooperatif untuk dilakukan pemasangan NGT, ini tentu perlu teknik di mana kita harus menumpulkan gejolak hemodinamik. Ya. Kalau kita menggunakan golongan opioid tentu kurang pas ya masalahnya. Kalau kita menggunakan opioid mungkin next-nya akan terjadi depresi napas. Nah, mungkin kita bisa menggunakan lidocain untuk menumpulkan gejolak hemodinamik ini. Nah, mungkin dengan lidocain 1 sampai 1,5 mg per kilogram badan mungkin akan cukup tidak menimbulkan gejolak hemodinamik. Kemudian siapa yang berhak melakukan? Tentu kalau untuk intubasi dokter lah, apalagi di ICU di situ ada dokter anestesi. Saya kira kompetensi dokter anestesi untuk melakukan intubasi sekalian pasang NGT. Nah, sekarang kalau misalkan pasien ini belum terpasang, belum memerlukan pemasangan intubasi, ya mungkin ya dokter saya kira lebih baik, ya, karena itu memang untuk invasif, walaupun kadang-kadang di kita banyak yang dilimpahkan ke perawat. Ya. Tapi kalau saya lebih prefer kalau dia melakukan adalah dokter. Terima kasih dokter.
Terima kasih Dokter Sudadi. Ya. Pertanyaan kedua dokter, jika pasien stroke iskemik datang dengan onset baru, masih di bawah 3 jam dari onset. Jika kita tidak memiliki terapi seperti RTP atau fibrinolytik lainnya, apakah ada alternatif lain yang bisa digunakan sebagai terapi inisiasi atau reperkusi? Seperti intravena UFA atau LMWH. Monggo dokter.
Ya, oke. Ya memang rekomendasi dari guideline adalah kita menggunakan tisu plasminogen aktivator ya, RTPA. Jadi kalau misalnya enggak punya, aduh saya enggak punya jawaban kalau yang ini. Kalau kita menggunakan golongannya low molecular heparin kan setelah 24 jam. Mungkin Dr. Putu bisa ada jawaban dokter.
Silakan Dr. Putu, ada tambahan.
Saya kira cukup dok. Saya kira cukup.
Oke. Dari guideline tidak disebutkan itu. Cuman memang disebutkannya kalau waktunya saja, jadi kurang dari 3 jam atau mungkin kita tidak tahu kapan onsetnya mulai terjadi. Nah itu runtutannya ada. Tapi kalau tidak ada sebagai substitusinya, saya tidak menemukan di situ. Terima kasih.
Terima kasih. Thank you, Dr. Sudadi. There's any question to Dr. Cintet or Dr. Leong? Please, we can see to committee. Okay. To Dr. Leong. Oh, sorry. To Dr. Chong Cintet. In the event of hemorrhagic transformation after thrombolytic therapy for ischemic stroke, if the patient is subjected to emergency decompressive craniectomy, would you consider use of PCC? If yes, what do you use? Dr. Cintet?
First question, is it in the event of hemorrhagic transformation after thrombolytic therapy, if the patient... Sorry, is it first question? I didn't catch.
Yeah. If the event of hemorrhagic transformation after thrombolytic therapy for ischemic stroke, if the patient is subjected to emergency decompressive craniectomy, would you consider use of PCC?
Okay, I personally have not encountered this scenario. Yeah, subject to emergency. Yeah, I would lah. It would depend on the patient body weight. Yeah.
Okay. The second question: why blood pressure control in ICH accurate is around 140 to 180? If the systolic pressure was below that range, is any consideration to using drugs support? And what drugs you recommendation?
Oh, okay. This one I answered in the chat already.
Okay.
So usually the blood pressure recommended is because of the ATTACK-2 trial. So they divide into two groups. Group 1 is 140 to 180. The other group is 139 and below. And they find that the second group, 139 mmHg and below, no increase in benefit for neurologic outcome, but it is in fact associated with more renal side effect. So that's why they recommend no need to go lower than 140. Yeah, and then what drug usually we recommend? So if systolic pressure below, okay, if below the range, okay, as I mentioned in the chat, usually it is high rather than low. High because usually the patient has got chronic hypertension, poorly controlled, and then have hypertensive bleeding. Or is usually high because it is part of the catecholamine response to raise intracranial pressure. So if it's low, then you have to think of why is it low? Maybe it's excessive drug use, like too much propofol for the sedation and tube tolerance, or maybe it is due to too much drugs, like too much labetalol, or maybe it is due to already brain herniation. Yeah, or maybe it is what do you call that? Bleeding or whatever. So you have to exclude why it is low, because usually it is high. If it's low, then maybe it's already, as I mentioned, already quite serious, or already impending brain death, already brain herniation. Then this is another matter altogether. It is not talking about prevention of hematoma expansion. Yeah, it is more like trying to sustain organ perfusion, including the brain. Then usually I can recommend start some vasopressor like noradrenaline. So yeah, so I have seen like patient low because already brain herniation, but because you want to maybe keep patient alive for organ donation, because in Singapore we have the human organ transplant act, then sometimes we want to start some noradrenaline, even though if already brain dead or already brain herniation, so to support organ perfusion for potential organ donation. Yeah.
Okay. Thank you, Dr. Cinta. The third question, what is our anesthesia recommendation to facilitate thrombolectomy? Is there any certain consideration?
Okay, thrombolectomy for acute ischemic stroke?
Yeah.
Okay, but my topic is on hemorrhagic stroke.
Okay.
Yeah, but anyway, for thrombolectomy, outside of my topic of hemorrhagic stroke, in thrombectomy in Tan Tock Seng, usually we have two methods. One is conscious sedation, another one is general anesthesia. So it depends on many factors for whether conscious sedation or general anesthesia. For example, what is the patient GCS? Is the patient cooperative? Then what does the neuroradiologist think about the thrombectomy? Is it easy? Is it going to be long? If it's difficult or if it's long, then usually general anesthesia with intubation. And whether patient cooperative or if already unconscious, then you need to protect the airway, then usually it will be GA. Yeah.
Okay.
That is for thrombectomy.
Okay, thank you. And the last question, how do you administer nicardipine as an alternative to labetalol infusion in case patient is contraindicated for labetalol in controlling in the blood pressure in intracerebral hematoma?
Oh, okay. This one I also answer in the chat group. So usually IV nicardipine, we can run infusion 3 to 5 mg per hour for the first 10 to 15 minutes. And then after that, depending on what is the blood pressure response, you can increase it by 0.5 to 1 milligram per hour to try to achieve your blood pressure target. But usually we don't use more than 15 milligram per hour. So this is how we use nicardipine infusion.
Thank you, Dr. Cinta.
Thank you.
Okay, a question for Dr. Leong, which is not answered in the chat room. Okay.
Okay, let me answer the first question from Dr. LD.
Okay.
Have any experience in NIRS for monitoring cerebral condition in the ICU? Okay, so like NIRS, we use it quite a lot in anesthesia, right? So in perioperative setting, we use it quite a lot. In ICU, I've not really seen a routine use of NIRS, but come to think of it, the issue with NIRS is just, I mean, like they only monitor oxygenation, right? It doesn't monitor function. So then there's one downfall of NIRS. And the other problem is like there's no established baseline or like a cutoff point that we say that the reading is impaired, because everyone has different baseline, and patient with impaired cerebrovascular reactivity or patient with cerebrovascular disease might be even lower, right? So, but in fact, let's go down to perioperative setting, like in the case of an atherectomy or cardiac artery stenting. If patient is at risk, rather than monitor NIRS, we actually monitor EEGs, right, and SSEP, right? So that's question number 1. Okay, from Dr. Hashizan, encounter any incidents of CHS? Yes, I do. I've answered this in the chat group as well. I've seen a patient, and she's a very unfortunate lady who has unilateral MCA bypass. So unfortunate for her, like she was extubated quite well with blood pressure within target range. Then unfortunately, the next day when I came to work, I was informed that she actually had the cerebral edema and she actually fitted. So we have already looked through the chart. So apparently in the ICU, her blood pressure was actually on the high side, especially overnight. So like I strongly think that the management for this patient should start in the OT itself. So like at the end of anastomosis, we should communicate with the surgeon. Is that the blood pressure that you wanted, and what is the blood pressure target post-operatively? And we should actually continue this until like they review it or we review it in the ICU.
Okay.
Right.
Thank you. The third question.
Okay. Is there any role for osmotherapy? Okay. So again, so as I presented just now, the role of osmotherapy. I mean, there's no role for prophylactic osmotherapy. Okay, but there is certainly a role when it is used as a treatment for cerebral edema. Right. Then the mannitol was previously favored because they said there's actually a potential benefit of them mopping up the free radical free radicals. As a result, there's actually a lowered risk of reperfusion injury. But again, like this theory has sort of fallen out of favor. Right. Again, so like to answer your question, there's no role for prophylactic osmotherapy, but there is a role if it's being used to manage cerebral edema.
Okay, thank you, Dr. Leong. There is any other question? Okay. Okay, to Dr. Putu. Berapa dosis unfractionated heparin yang dokter sarankan untuk terapi CVT?
Dr. Putu masih mute.
Oh iya, masih mute, Dok.
Terima kasih banyak.
Berapa dosis unfractionated heparin yang dokter sarankan untuk terapi CVT?
Masih mute, dokter. Dr. Putu masih mute.
Mic-nya, Dok.
Terima kasih banyak. Jadi ada trouble sedikit.
Oke.
Berapa dosis UVH ini untuk terapi CVT itu 5.000 unit, tapi yang jelas targetnya adalah INR antara 2 sampai 3. Jadi targetnya 2,5. Kemudian apa obat antiepileptik pilihan untuk prevensi kejang pada pasien CVT? Dan berapa lama harus diberikan. Jadi phenytoin masih jadi pilihan, walaupun seperti kemarin sudah diungkapkan Kepra atau itu juga bisa diberikan karena side effect yang mungkin lebih singkat. Tapi yang jelas obat antiepileptik ini semuanya memang terapeutik dose dengan therapeutic range-nya dengan safety range-nya memang relatif dekat. Tetapi untuk CVT dia sangat bermanfaat karena 70% pasien ini akan tampil dengan kejang, apalagi lesinya di fossa posterior, di anterior. Kemudian from Charles, what time should we start when we should start the anticoagulation therapy for confirmed CVT? There is a contraindication for consideration, and what is the recommendation? If the patient needed for a surgical approach due to anticoagulation therapy, using anticoagulant therapy. This is CVT, as we know, this is a very rare form of stroke. This maybe last to see we see the CVT. So headache may be going on for a few days, and this is not very immediate like a stroke, even this is a form of stroke. So when they already confirm radiologically, so we should start immediate anticoagulation. Is there any consideration for a contraindication or consideration? Even this is CVT, cerebral venous thrombosis, mostly happen in younger adult or then patient with risk factor, like using contraceptive or still in the younger adult. But if we see this in the older groups, we should using anticoagulation more cautiously. Even we know we have target INR 2 until 3, 25, 2.5 in the fleets, but we should be careful because easily we will get INR higher than that. If the patient needed surgical approach and we using the anticoagulants, maybe we can reverse, but we should see the risk and benefit, mostly the most important. And the other one, I think I already answer all the related question. Thank you, Dr. Himawan. Terima kasih banyak, Dr. Himawan.
Yeah, thank you, Dr. Putu. Ladies and gentlemen, we have arrived at the end of the first session of second day symposium. We would like to all speakers. Thank you for all speakers, Dr. Sudadi, Dr. Shintet, Dr. Leong, and Dr. Putu Pramana Suarjaya.
Very much.
We would like to thank you for all participants and organizers and the sponsors who have support this event. It can be carried out well. See you in the. Thank you for your attention, and see you at the 2 years before now. Thank you very much for the attention. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh. Saya kembalikan ke MC. Terima kasih. Selamat pagi.
Thank you, speakers and moderator, for the first session of plenary lecture.
Before we entering for the next session,
we proudly present a glimpse of the history and culture of South Kalimantan.
Bulik pangsa tuman, lawasnya lemah hadang, pian meninggalkan kampung halaman, kapal purunan. maka inilah saatnya. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan Selatan. Kamilau intan bumi cempaka, ragam kuliner yang menggoda, kasturi floranya, bekantan satwanya. Terjaga budaya pasar terapungnya. Semua hanya ada di sini. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan Selatan. Ayo, ayo ke Kalimantan Selatan, beraneka destinasi wisata. Ajak semua sahabat dan keluarga ke Kalimantan
Thank you for your attention. Before entering the second session, we will introduce those who act as speakers and moderators. We have 4 speakers. Professor Haikyu Kim from South Korea,
Dr. Buyung Hartio Laksono, Neuro Anesthesiologist Consultant, Fellow of Pain Management from Indonesia.
Dr. Geraldine Rafaela Jose from Philippines,
Dr. Chong Sang-yi from Singapore.
and for the moderator, Professor Dr. Tatang Bisri, Neuro Anesthesiologist Consultant, Obstetric Anesthesiologist Consultant.
Before we hand over the host of the session to the moderator, allow us to read a little CV about him.
He was graduated from Medical Faculty of Pajajaran University. Then he continued his studies as anesthesiologist and advanced his studies as neuro anesthesiologist consultant, obstetric anesthesiologist consultant, and doctoral degree at Pajajaran University.
Now, he served as Professor, Department of Anesthesiology and Intensive Therapy, Faculty of Medicine at Pajajaran University, Head of Center for Neuromuscular Studies, and Head of Anesthesia Specialist Education Studies, Neuroanesthesia Consultant.
We welcome you, speakers and moderator. To Prof. Tatang, the time is yours.
Thank you. Thank you to MC for introducing me to audience. Welcome to the Brains and Spinal Cord Symposium, which is the last session of the Indonesia-Singapore Joint Symposium on Neuro ICU. There were 4 speakers: Professor Haikyu Kim from Busan, South Korea, Dr. Buyung from Indonesia, Professor Geraldine from Philippines, and Dr. Chong Sang-yi from Tan Tock Seng Hospital. To all speakers, welcome to Indonesia. Welcome to the symposium. But Professor Haikyu was suddenly unable to attend because in the same time there was something that could not be left behind. But he allowed to show his slide or video. Professor Haikyu Kim is, this is the CV from Professor Haikyu Kim. He is from Department Anesthesia and Pain Medicine, Busan National University, South Korea. Please help to the committee to show Professor Haikyu slide or video.
Selamat pagi. Good morning, ladies and gentlemen. It is my great pleasure to give a talk at the Indonesia-Singapore Joint Symposium. Before starting my talk, there is no conflict of interest in this presentation. I lived the distance from Busan to Banjarmasin from here to here is about 4,537 kilometers. I'm working at Busan National University Hospital for 40 years. Let's start today's topic. I would like to talk about ICU management of brain tumor patients after surgery. Why we need it for postoperative intensive care, and I'd like to talk about the management after brain tumor surgery, and I would like to talk about the need to change automatically ICU shifting strategies. First of all, why we transfer patients to ICU after surgery? Following craniotomy for brain tumor dissection, it is recommended that all patients be observed closely in an intensive care setting for more than 12 to 24 hours. Because of we would like to detect serious post-operative complications early and facilitate rapid intervention, and to optimize the reestablishment of systemic and neurologic homeostasis, allowing overall fast recovery. This slide shows the post-operative complication after craniotomy for brain tumor surgery. This data came from a French hospital. This table shows the incidence of complications during the first 24 hours following brain tumor surgery. As you can see, the most commonly occurred complication is the POM bleed at 25%, and then the new motor deficit and the deterioration of consciousness, like the neurologic complications, 16%, and hypertension and hypoglycemia. So this kind of complications make us to transfer the patient to the ICU. You see, this table is proposed criteria for admission to ICU after elective craniotomies. Especially post-operatively, you see this kind of complications. So it needs to intensive care. Recently, Their proposed prediction score for post-operative neurologic complications after brain tumor craniotomies. This study used this kind of parameters: cross-coma scale, and history, size, and the midline shift, and transfusion, and blood pressure, and the duration of surgeries. From these parameters, they made it like cranial score formulas. You see, these formulas is very complicated, but when we get the cranial score values less than 3%, it is a very low risk patient from post-operative complications. But more than 30%, it means very high risk patient from post-operative complications. When the patient admit to the NCCUs, we would like to predict the stay. This kind of predictors means the patient stayed more than 1 day in NCCUs. Higher tumor severity score, higher intraoperative fluid score, and the post-operative intubation. The duration of surgery is more than 7 hours. And the new post-surgical hemiparesis or low cranial nerve deficit. Also, intraoperative use of vasopressin therapies for hypertension can be predicted long stay. How to intensive care after brain tumor surgery? The most important one is clinical monitoring and the radiologic monitoring. You would like to check the level of consciousness. If the sudden or maintained changes during neurologic examinations, we should assess the need to perform CT scan or MRI. As you know, most of the people to admit ICU have the intubations, so respiratory monitoring and the need for mechanical ventilations. So at the end, we would like to sedate and get the pain controls. So it needed fluid therapy and electrolyte alteration control. And the post-operative prophylaxis is needed. Especially in intensive care settings, we would like to do post-operative neuro monitorings, like the intracranial pressures and the CBF and the cerebral oxygenation and cerebral metabolism. In here, recently we used cerebral oximetry for measuring cerebral oxygenations, but this is not recommended because there is little evidence available. Respiratory monitoring and need for mechanical ventilations. Neural dysfunction is one of the leading causes for mechanical ventilation. Its goal is maintaining a patent airway. And ventilated neurologic patients require the long ICU stays, also have a higher tracheostomy ratio, and use PEEP therapy for short period of pains. Mechanical ventilation has the level of PEEP less than 5 cm H2O because of avoiding increasing ICPs. But recently, other reports that it is safer to use higher levels of PEEP since this higher level improves the oxygenation of the brain. Mechanical ventilation, in mechanical ventilation, we did not recommend to keep prophylactic hyperventilation for long periods of time to reduce PCO2. Most common complication, POMV. The incidence of POMV after craniotomy is for the case of without prophylaxis, 22 to 70%. If we do prophylaxis, the incidence is 60 to 60%. You see the previous report. You can see the possibly now the vomiting incidence is 25%. POMV had adverse results, leading to the increased ICP, intracranial hemorrhage, and cerebral herniations. Also intensified the risk for post-vomiting aspirations. If the POMV occurred lately, 72 hours after craniotomies, it may relate to intracranial hypertension rather than a classic POMV. This table shows post-operative nausea and vomiting and studied risk factors. In here, you see the premier sex and the younger age and the duration of surgery more than 60 minutes is the most important factors, especially after craniotomies. This compared the upper scores and the recent risk factors for POMV in adults from this journal. So how to management of POMV after craniotomy? Actually, prevention is the best. Awake craniotomy patients show less POMV than general anesthesia patients. Also, Society of Ambulatory Anesthesia guideline shows ondansetron, prepitant, and dexamethasone combination therapy to prevent POMVs. If the patient is admitted in ICU, dexmedetomidine within the first 90 minutes after surgery can show the good result to prevent POMV and treatment of POMV. Actually, the multimodal regimen has been recommended, like ondansetron and dexamethasone. The combination is the most frequent use and effectiveness. How to sedate and how to pain control. Actually, the goal is to be able to open neurologic window frequently. Deep sedation may increase the number of days on mechanical ventilation and make delirium and increase mortality. So mild sedation and the use of analgesia is best choices. You do not recommend the use of the benzodiazepine, so non-benzodiazepine drugs recommended. Fluid therapy is electrolyte alteration control. Usually in ICU, we use the isotonic solution, but always avoid hypotonic solution. For the colloids, there is no significant difference in mortality with the use of colloids compared to the use of crystalloids. And for the hypotonic solutions, we would like to use to reduce brain swellings. but there is no difference between hypertonic solution and monitored in the management of intracranial hypertension. There is a hyponatremia and hyponatremia. Hyponatremia is the most common electrolyte disorders. To treat the hyponatremia, we would like to infuse one hypertonic saline solution. Hyponatremia is a diabetes insipidus is characterized by dehydration with hyponatremia. We treat it is based on hydration and usual ADH analog such as desmopressin or vasopressin. Management of vasogenic edema in patients with primary and metabolic brain tumor. Usually we use the glucocorticoids. It is the mainstay of therapy for symptomatic peritumoral edemas. Commonly we use the dexamethasones. This one is commonly used this due to its potency and lack of mineralocorticoid activity. And in ICU, we do the post-operative prophylaxis, like the use of antibiotics and preventing seizure and antithrombotic prophylaxis. Usually for the antibiotics, especially prevalence of surgical wound infection is between 1% and 11%. The most common isolated germ is Staphylococcus aureus. For the preventing seizures, there is some controversies for preventing seizures. Recently, there is two reports. Indian Journal of Neurosurgery. They said early post-operative seizures are caused due to the surgical injury and stress response. So you must control about this one, and late post-operative seizure represents epilepsy and requires long-term seizure prophylaxis. But in this data, they showed that there is no problem capability of reducing the onset of epileptic seizures. So they did not recommend the routine use. But in my hospital, we use commonly preventing drugs. During the management the patient in intensive care unit, we would like to consent the post-operative delirium. Pre-operative risk factor for post-operative delirium in brain tumor is like depression and the psychoactive medications, electrolyte abnormalities, pain, decreased cerebral acetylcholine productions, cerebral ischemia, elevated ICP, reduced CPP, neuroinflammation, oxidative stress like this one is increasing factors to POD. Also, there is another factors, neurosurgical induced brain injury also very important factors. For these post-operative delirium factors, risk factors, so we must consult these factors if we use some drugs. This is the management of POD risks. So it needed adequate pain controls, and where we need to well sleep in ICU. But extensive use of sedative drug makes adverse effects. And we must think about the cholinergic systems. Anticholinergic drug induced toxicity makes the POD and the geriatric patient also has this kind of POD risk. And do not use atropine, benzodiazepine, gabapentin because it may affect cholinergic systems to development POD. Neurosurgical pathologies, the most common one is hyponatremia after hypophysiectomy for pituitary tumors. So we must concern of the POD risk increasing. How to prevention of POD? Actually, the best way to manage POD is its prevention. The most promising method of preventing POD is adequate perioperative pain management, optimal depth, and acid-base balance maintenance, glucose electrolyte control, and good sleep, and early activation and rehabilitation is very important. Recently, they need to change the ICU shifting strategies instead of automatically ICU shifting. Because of we would like to decrease post-operative complications and we would like to reduce hospital costs and we would like to save ICU ability for acute patients. In these studies, they evaluated the length of stay and evaluated the complication development. From these studies, they can found the cost reduction and the complication was significantly reduced. So they concluded this kind of selective intensive care unit admission may reduce complication rate and the length of stay in the hospital while keeping patients satisfied. Hospital costs are also significantly reduced. Another recent report, they would like to use the safe transition pathway model. So they would like to check and they conclude the length of stay, direct cost per case, and ICU date was significantly less after adoption of the safe transition pathways. How to organize the neuro transitional care units? You see this at the NTCU level is nursing is stepped at the ratio of 2 to 3 patients per nurse, and the neurological examination and vital check can be performed every 2 hours, and the continuous monitoring are done for 24 hours. Previously reports they showed the monitoring in ICU and the moderated care unit and the ward that you can compare this ones. Very higher levels neurologic monitoring is occurred only in ICUs. This slide shows the admission criteria for NTCU. The patient age is less than 65 years, but the later of studies they included older than 65 years, so there's no age limitations, no premorbid conditions, and the planned routine craniotomy, especially less than 3 cm in size, is important, and no intraoperative adverse events. Over operating time is less than 5 hours, and the blood loss is less than 500 ml, and routine extubation is needed. This one is take-home message. Thank you for your attention. Happy New Year's. We can overcome COVID-19 pandemic. I would like to look forward all of you in near futures without COVID-19. Thank you very much.
Thank you to the committee for showing Professor Haikyuu Kim video. And discussion will be held after all speakers have finished presenting, and question please write in the question and answer column. And we invite the second speaker, Dr. Buyung Hartio from Department of Anesthesiology and Intensive Care, Universitas Brawijaya, Saiful Anwar Hospital, Malang, Indonesia. Time is yours, Dr. Buyung.
Turun, Prof. Panitia izin saya share screen.
Ya, silahkan panitia.
Oke. Dapat terlihat, Prof?
Terlihat jelas, jelas.
Oke, terima kasih. Thank you for everybody participant. I will talk about the topic is critical care management for patient with spinal cord injury, setting in neuro intensive care unit. I will give you about one illustration case. Male, 36 years old, history falling from the of 4 meters, coming in the emergency room with a complaint of pain in the neck, hand and feet difficult to move, feel numb from the lower neck to the tip of the foot, abdominal breathing, blood pressure decrease, pulse rate decrease, GCS level for 5 and plagia. There is trauma head to the head with conservative treatment. Neurosurgery built for ICU treatment. Yes. So for we in the anesthetist or neuro intensivist, we must manage this patient in our ICU. We must estimate the level for illustration case. I think maybe there is dermatomal is between cervical 3, 4, and 5. It is important. We must knowing about the level of the injury of the spine. That patient have a radiologic diagnosis and MRI result for there is posterior listhesis, C4 and 5. There is anterior fracture, corpus C5, narrowing of the spinal cord 3, 4, and 5, accompanied by edema of the subspinal medulla. This right with the dermatom of the level injury. What the problem can be occurs for that patient? Spinal cord injury induces human depression syndrome. Many problem, physiological problem, anatomical problem that have been in our patient in intensive care unit. ICU related spinal cord injury patient. The principle is avoid secondary injury and complication. What? Avoid hypotension and respiration issues. With spinal cord injury is pneumonia, septicemia, pulmonary embolism. Another cause may be infection, thromboembolic event, and skin breakdown. All of the problem is about airway, breathing, circulation, disability, and exposure problem for the patient. As you care, improve outcome through decreased mortality and cardiorespiratory morbidity. The first, airway and breathing management. The most problem is ventilation failure, pneumonia, and atelectasis. We know about physiological of normal breathing. There is for the muscle, intercostal muscle, scalene muscle, sternocleidomastoid muscle, and diaphragm. The important is diaphragm. Diaphragm supplied by cervical innervation from C3 and C5. There is contribute about 65% of vital capacity. The pulmonary mechanism in the spinal cord injury, altered in cervical spinal cord injury because of change in mechanical property of the lung, reduction in the lung volumes, and then gastric distension because of secondary compression of gastric atonia. What the effect is a significant reduction of lung compliance and increases volume of breathing of the patient. Yes, from pulmonary function have problem is in the first 1 to 3 days. Substantial decline of pulmonary reserve may occur before overt clinical signs are seen. It is important. Diaphragm may be initially function. Progressive cord edema may be occur in the over the first 2 days. Be careful. There is ascending neurological injury, loss of diaphragm function, and can be rapidly progressive respiration failure. Pulmonary function, there is acute after injury, significant reduction in tidal volume, vital capacity is important in the cervical SCI and cervical 5 and 6, and worse if the level is C4 and above. After 3 weeks, significant improvement on lung volume for up to 5 months after injury, substantial progress we can perhaps. There is the table of levels of spinal cord injury and corresponding respiration function. The most of trauma level is in the C3 and C5 because a doom of angulated of the cervical is in this level. So we must knowing about the problem must be occur for the injury level. In that case, what we must do? Yes, there is early intubation, mechanical ventilation, and early tracheostomy. How about ventilator setting? The target is limit the occurrence of ventilator-associated lung injury. Tidal volume is about 6 up to 8 milliliter of body weight. There is PIP 5 ventilator rate about 8 up to 50 breaths per minute. That's the important PIP level is lowering above 30. Tracheostomy. We must nearly all patients with complete cervical spinal cord injury above C6 because length of ventilator time difficult with chlorine secretion. what must we do in the early 3 up to 7 days from the time of injury? There is delayed tracheostomy as little benefit. Because early tracheostomy advantage, reduction in airway dead space, airway resistance, improve pulmonary toilet, easier to suctioning, early spontaneous breathing trial, more comfort for the patient, and reduction in the incidence of ventilation-associated pneumonia. How about bronchoscopy? Fibratic bronchoscopy may be needed in the 2 weeks following acute cervical spinal cord injury. The aim is to remove secretion. It is important to remove secretion because there is clinical significance of problem of the pulmonary is lobar atelectasis and complete bronchus occlusion. The patient is inadequate clearance of secretion. When VAP is suspected, there is early and aggressive broad spectrum antibiotic. Kinetic therapy, there is effective for reduction incidence of pulmonary complication. From the evidence base, maybe LTA, decreases time of ventilator, shortening length stay in the ICU, reduction hospital resource utilization, reduction of overall morbidity and mortality. Should be start early. Should achieve rotation of angle about 45 degrees. This may be new in our therapy is diaphragma pacing, especially in the tracheostomy patient, promising enhancing for feeding. Okay, so I can be give a protocol for reduction pulmonary complications. The first is aggressive pulmonary region. There is suctioning, nasotracheal, positioning, chest percussion, assisted coaching, deep breathing exercise, and spirometry. The second is bronchodilatator therapy. The third is early use of fiber optic bronchoscopy for lobar atelectasis secondary to retained secretion. Early institution of mechanical ventilation and close monitoring air respiration mechanic with optimal of PEEP, therapy limitation, play to pressure to lowering the 13 mm mercury. What about cardiovascular management? There is the two problem, yet very fatality and most common in the patient. The first is neurogenic shock, and the second is hyperreflexia syndrome. And we we can so for the monitor for the patient above, there is decreasing of hemodynamic, blood pressure, and then pulse rate. What will happen? Neurogenic shock, yes. Common problem with cervical spinal cord injury. Usually occurs at above T6 injury. Because sympathetic cardiac innervation will not arise from T1 and 6. What the manifestation? Hypotension, bradycardia, and due to low sympathetic tone may contribute to secondary damage. The more cephalate, the more severe physiologic derangement. From identification and treatment is very essential, and the problem can be happen in the last for 1 and 2 weeks. Yes, you know the cardiovascular effect of spinal cord injury. Yeah, there is many problem about cardiovascular instability, dysrhythmia, ventricular dysfunction. Bradycardia present in the all patients with complete cervical spinal cord injury, less likely in the thoracic and lumbar spinal cord injury. result from interruption of sympathetic cardiac accelerator nerve, and then unopposed parasympathetic influence. Maximal on day 4 after injury. Usually resolve over 3-5 weeks after injury. And then in the chronic spinal cord injury, there is risk cardiac dysrhythmia decrease with time and eventually disappears. More profound decrease. Event cardiac arrest occur during patient stimulation. During tracheal suctioning, maybe it is important, yes, for the nurse ring to prevent. What to prevent? Give the sedation. 100% U2 before suctioning. Limiting time allow for suctioning. Atropine and temporary pacemaker. Most problematic during the first 2 weeks after acute cervical injury. Hypotension, yeah. Systemic blood pressure less than 90 millimeter mercury or 30% below baseline. This most of acute cervical injury patient. Recommendation: the MAP is above 85 millimeter mercury for the first day. 7 days following acute spinal cord injury. Because autoregulation is lost after spinal cord injury. Judicious of fluid and vasoactive medical are crucial for correction the hypotension and optimal preservation of neurologic function. Fluid management, we know is hypotension, but initially treated with fluid, but cautiously limited overall volume because of can be developed cardiogenic and non-cardiogenic pulmonary edema. But hypotension persists despite adequate fluid admin, vasopressor, and inotropic therapy. Yeah. Isotonic crystalloid, the initial fluid of choice. How about hypertonic saline? There is additional benefit in initial resuscitation. Vasopressor. The agent of choice of vasopressor, we give potent IV alpha agonist agent, norepinephrine, phenylephrine, and dopamine. The point to consider is carefully. Substantial increases in cardiac afterload, impaired cardiac output, precipitated left ventricle value. Inotropic agent can be added to optimize spinal cord perfusion. Invasive or non-invasive monitoring, it is important, recommended for guidance this vasopressor therapy. Improvement neurologic octave in spinal cord injury patient whom SD are managed aggressive during the first 3 up to 6 days following injury because of spinal cord edema is maximum. Recommendation: the MEP is above 85 for 70, and cervical hyperregulation with both hypotension, bradycardia, drug like norepinephrine with chronotropic and inotropic effect, as well as vasoconstrictor property might be required. Okay. And then, in the 5 days of treatment, patient complains of abdominal pain. Then patients with cold, shortness of breath, severe headaches, blood pressure, and increasing of pulse rate. Patient unconsciousness with cardiac arrest incident. You can see from the monitor what happened to the patient. Yes, there is autonomic hyperlactasia syndrome caused by hyperactive spinal reflex, without tempering effect of modulating cortical and brain and cerebral influence from the patient. There is occur high frequency in patient spinal cord transaction above T5. Usually begins to appear 2 and 3 weeks after injury because of the body reaction to pain or discomfort an area body below the level spinal cord injury. there is what the sign, blood pressure rise sometimes to very dangerous level. Potential leads to the stroke, heart attack, seizure, and death. Yes. It is pathophysiology. I skip. What we can do, we find and treat the cause. Hypertension, we can give direct acting vasodilator, sample sodium nitroprusside, beta blocker with combination with alpha blocker with calcium canal blocker, nicardipine, ganglionic blocking agent like trimetapan. Maybe we need deep general or sedation. How about in gastrointestinal system, nutrition, and alimentation? The complication can be happen as ileus, gastric atonia, bowel obstruction, constipation, abdominal bloating, fecal incontinence, pancreatitis, and alkalosis cholecystitis. Gastric dilatation because of gastric emptying rates decrease, excessive gastric dilatation, gastric detention, and then risk of regurgitation and aspiration for the patient. Early placement of NGD because of HEP limiting distension, reduction of the risk of regurgitation, minimize adverse effect of diaphragm and pulmonary system. How about gastric irritation? Because of patient with mechanical ventilation and high dose corticosteroid, maybe increases of this problem. Give prophylaxis treatment, H2 blocker or PPI. Okay. Early feeding, prophylaxis against stress ulcer, stool softener, and bowel program. That is for elementary. How about temperature, thromboembolism, and pressure ulcer? Temperature control. In patients with complete spinal cord injury, body temperature tend to approach the environment due to inability to conserve heat in cold environment in ICU by vasoconstriction and to switch to hot ambient condition. Okay, you must cool the patient temperature is normal and mild hypothermia. So hypothermia should be aggressive treated. Hypothermia, we can give the patient blanket. And then the problem with the patient can be occur is neurogenic fever. That is 48% in patient with acute spinal cord injury. The temperature is more than 40. Because of the thermal dysregulation in the thalamus. We must aggressive treated by cooling and distributing the producer. And then how about venous thromboembolism? Many topic is maybe talk in the before panelists refers to both DVT and pulmonary embolism. So we must diagnose this case in the spinal cord injury. Clinical observation with combined D-dimer level. Maybe when we have facility can doing venography, color flow duplex, CT angio, and pulmonary angiogram. The prophylactic treatment soon after injury. 72 hours after injury, yes. Continue minimum 3 months. We can give low dose unfractional heparin, low molecular weight heparin, but except in the case untreated unstable fracture or presence of spinal epidural hematoma. And then mechanical prophylaxis, we must do intermittent pneumatic compression device and early mobilization for the patient. This pressure also the problem here. There is direct pressure of the because immobility of the patient. we can and then reduce tissue perfusion to patient and limited mobility. What can we do to prevent? Give rotational beds, frequent patient turning, good skin care, foam bedding, and body prominence are air floating beds. Okay, it is a summary of all the problem can be managed for a spinal cord injury patient in the intensive care unit. Summary of the topic: SCI is complex challenge for anesthesiologists. Fundamental knowledge of initial neurologic assessment, acute medical management strategies, and complications associated with chronic spinal cord injury will facilitate limitation of further neurologic deterioration. Okay, thank you for the attention. Time is back to the Pratata. Thank you, bro.
Thank you very much, Dr. Buyung, for a very nice presentation. For next speaker, I invite Professor Geraldine Rafaela from Philippines. She is Associate Professor at University of the Philippines and Philippine General Hospital. Also President of Philippine Society of Neuroanesthesia and Critical Care. Professor Geraldine, time is yours.
Good day, Professor Tatang Bisri. Thank you very much for this kind introduction and invitation to participate in the second Biennial Neuro ICU Symposium of Indonesia and Singapore. It is such a privilege to be here, and it has been a very successful meeting. The topics are really very important and informative. So may I ask permission to share my slides, please? Can you see my slides, Professor Tatang?
Yes, very nice. Yes,
okay.
Very nice.
All right, thank you. So I would also like to thank Dr. Kinanga for the invitation to speak in this conference. So for this morning, I have been tasked to give a lecture on the care of patients with neuromuscular disorders in the intensive care unit. So at the end of this session, the participant will be able to describe the contributing factors to neuromuscular weakness in relation to critical illness, make diagnosis of neuromuscular weakness in relation to critical illness, discuss the pathophysiology of critical illness myopathy and polyneuropathy, summarize the clinical manifestations for these conditions, identify the differential diagnosis for neuromuscular weakness in the ICU, and describe the varying intensive care needs for each disease entity, and provide practical guides for management. There are no conflicts of interest in delivering this lecture. We start off our discussion with the case of a well-nourished 77-year-old man whose medical history includes treated hypertension and hypercholesterolemia, with previously heavy alcohol intake and mild cognitive impairment. He is admitted in the intensive care unit of the University Hospital from the operating room after a Hartmann's procedure performed for fecal peritonitis due to a perforated sigmoid colon. On arrival in the ICU, he was in septic shock. He is undergoing mechanical ventilation with the use of low tidal volume protocol with positive end expiratory PEEP. His arterial blood pressure is supported with norepinephrine infusion, and analgesia is provided by morphine. continuously being given. Enteral nutrition was started on the day after ICU admission, and target intake was achieved on day 6. Parenteral nutrition was not utilized. On day 7 in the ICU, symmetric flaccid limb and ventilatory muscle weakness were observed, which led to attempt failure from weaning from mechanical ventilation. The extraocular muscles are relatively spared, but the facial muscles are noted to be very weak. Upon neurologic examination, the patient is fully awake and conversant, however, visibly weak. Tendon reflexes were also reduced. So how do we account for generalized weakness? Is there anything we can do to prevent this from happening? Since it is likely that this patient will have a prolonged stay in the ICU, what measures would you take to optimize his long-term recovery? Prolonged treatment in an ICU, and particularly prolonged mechanical ventilation, is associated with the loss of muscle mass and marked reduction in muscle strength, which is referred to as ICU-acquired weakness, also called ICU-AW. These are patients who have clinically detected generalized weakness with no plausible cause other than the critical illness. A common occurrence, and it occurs greater than 25% of patients who are mechanically ventilated in the ICU for at least 7 days. A consequence of improved survival in patients with multiple organ failure, systemic inflammatory response syndrome, and sepsis. It may also be associated with treatments administered. Critical illness myopathy, which is the most common form of ICU-acquired myopathy, is actually quite, as I've mentioned, common. But in comatose and encephalopathic patients, the time of onset of this disease process may not be known. The definitive characteristics of critical illness myopathy are severe muscle atrophy, affecting both type 1 and type 2 muscle fibers, preferential and selective loss of thick filament protein myosin leading to atrophy of myofibers, myofibrillar disorganization, and eventually sarcomere disorganization. There is increase in muscle apoptosis, oxidative stress, and electrical hypoexcitability of the muscle due to poor excitation and contraction coupling. This slide shows us a summary of intensive care unit animal model researches looking into neuromuscular weakness. ICU-AW interventions and triggers were identified, which include the use of neuromuscular blocking drugs, mechanical ventilation, corticosteroids, and sepsis. The duration of mechanical ventilation for the porcine model is within the range of 27 hours to 5 days, and for the rat model, up to 14 days. The ICU-AW hallmarks replicated in both studies were as follows. There is reduction of muscle force generation, decreased muscle membrane excitability, muscle atrophy, and preferential loss of myosin. Affected muscle groups in both models are consistently the diaphragm, the limbs, and the masseter. So let's talk a little bit about ICAW and COVID-19. Severe COVID-19 often becomes critically ill, requiring ICU care. Multifactorial conditions such as polyneuropathy, myopathy, and/or disused muscle atrophy results in muscle weakness. For survivors, long-term functional disability is observed, and post-acute rehabilitation programs are recommended. The exact prevalence of ICU, AW, and COVID-19 is unknown and not well delineated, but retrospective studies have shown that around 45.5% present with ICU, AW in COVID-19 patients in those with severe form. So the pre-morbid health status are those with sepsis, multiple organ failure, on mechanical ventilation more than 7 days, immobilization, on continuous neuromuscular blockade, corticosteroid use, and poor glycemic control. Early studies identified critical illness polyneuropathy, which is characterized by symmetric weakness affecting the proximal limb muscles through denervation and denervation atrophy. Critical illness polyneuropathy may also affect the respiratory muscles and delay weaning from mechanical ventilation. Critical illness myopathy is a primary myopathy that may be difficult to distinguish from critical illness polyneuropathy. Critical illness myopathy is more common than critical illness polyneuropathy but presents with similar weakness of limbs and respiratory muscles. The two conditions can coexist, and although they can be characterized and differentiated by electrophysiological studies and muscle biopsy analysis, such evaluations are often not technically possible in a critically ill patients. Coexisting polyneuropathy and myopathy are termed critical illness neuromyopathy. So these are the risk factors for ICU-acquired weakness, and this includes prolonged inflammation or sepsis, immobility, prolonged mechanical ventilation, uncontrolled hyperglycemia, and treatment with glucocorticoids or neuromuscular blocking agents. Here is an illustration of the differential diagnosis of acquired muscle weakness. The mnemonic is muscles, which is easy to remember, which can help in the differential diagnosis of acquired muscle weakness. M is for medications such as use of steroids, neuromuscular blockers, zidovudine and amiodarone. U for undiagnosed neuromuscular disorders such as myasthenia gravis, which is a myopathy due to abnormality in the neuromuscular junction. S for spinal cord disease, wherein there is ischemia, compression trauma, vasculitis, demyelination. C for critical illness myopathy and critical illness polyneuropathy. L for loss of muscle mass, cachectic myopathy, and rhabdomyolysis. E for electrolyte disorders such as hypokalemia, hypophosphatemia, and hypermagnesemia. S for systemic illness such as porphyria, AIDS, vasculitis, paraneoplastic syndromes, toxic disorders, and also COVID-19. How about neuromuscular weakness and glucocorticoids? It is a well-recognized side effect of corticoid steroid therapy. The risk may be increased in older or malnourished patients and in those with cancer. It may occur with the initiation of systemic treatment and in chronic maintenance therapy when the doses are increased. It develops over several weeks, and the proximal muscle weakness and wasting are the first to be noticed. Myalgia and muscle tenderness are basically not observed, and this is commonly observed when the daily dose of glucocorticoids is in excess of 40 to 60 milligrams per day, and clinically important weakness may be observed in 2 weeks. So diagnosis of glucocorticoid-induced myopathy is one of exclusion based on the timing of treatment and the absence of other causes of myopathy. The diagnosis is generally established by demonstrating improved strength within 3 to 4 weeks after dose reduction. There are 2 settings wherein diagnosis is particularly difficult, and these are when there's an underlying inflammatory myopathy and whenever the patient is treated with a neuromuscular blocking drugs given continuously. Of interest in this regard is a report of a 13-year-old girl with severe myasthenia gravis and respiratory failure requiring mechanical ventilation. Treatment with massive IV doses of glucocorticoids resulted to generalized muscle weakness and wasting. EMG suggested myopathy, muscle biopsy showed diffuse muscle atrophy, and anti-acetylcholine receptor antibody titers was strongly positive. It was speculated that neuromuscular blockade due to myasthenia gravis in this patient resembled the neuromuscular blocking agents in severe asthma, in sensitizing skeletal muscles to higher dose glucocorticoids and the development of an acute myopathy. Reduction of nerve excitability and axon degeneration may represent different ends of a single pathophysiologic spectrum that varies according to the severity of the inflammatory process in critical illness polyneuropathy, and that muscle membrane inexcitability myosin loss, and muscle necrosis comprise the pathophysiologic spectrum of critical illness myopathy. If you look at this image, there are actually two stimulations being given to this muscle through nerve stimulation and direct muscle stimulation. As you can see, as you compare the response of the nerve versus the muscle to the nerve stimulation in a neuropathy, the amplitude is definitely reduced or even becomes zero as compared to direct muscle stimulation. But in the case of myopathy, both the nerve stimulation and direct muscle stimulation show a reduced amplitude, and it may even show no response. Critical illness myopathy may occur within the ICU or the post-ICU setting. Current strategies to limit ICU-acquired weakness and optimize recovery from critical illness are focused around minimizing sedation and targeting early mobilization of patients even while they are still undergoing mechanical ventilation. In the ICU, patients who cannot be mobilized, passive exercises, or in-bed cycle or ergometry, neuromuscular electrical stimulation, nutritional supplementation, and hormone therapy may also improve recovery. Post-ICU, the treatment goal is to promote muscle repair post-ICU by blood flow-restricted exercises, targeting AMP-activated protein kinases and intramuscular injection of mesenchymal stem cells. There are no specific treatments that have been shown to prevent ICU-acquired weakness. In one study targeting normoglycemia, glucose concentrations between 80 to 110 milligrams per deciliter in critically ill medical patients was associated with reduced incidence of critical illness neuromyopathy and a reduction in the need for prolonged mechanical ventilation. These results were supported by a retrospective study from the same authors, but have not been replicated by others because the perceived adverse effects of targeting normoglycemia, current guidelines recommend starting the treatment with insulin in patients with blood glucose level of more than 180 milligram per deciliter, with a target of 140 milligrams per deciliter to 180 milligrams per deciliter. So we shouldn't be too strict with regards to glucose control. In this slide, the network of proposed pathophysiological mechanisms involved in the development of critical illness polyneuropathy and myopathy is shown. Critical illness polyneuropathy may lead to muscle denervation and eventually critical illness myopathy. Neuromuscular blocking drugs may bring about muscle denervation in the long run. Corticosteroids has been documented that it may have a myopathic effect in the critically ill as well. When we zero in and look into the further details, the pathogenesis of critical illness polyneuropathy and myopathy is complex, involving microcirculatory changes, metabolic alterations, electrical abnormalities, and bioenergetic failure. They contribute independently, simultaneously, or synergistically to the pathogenesis of this myopathy. Therapeutic strategies for critical illness polyneuropathy and myopathy is revealed in this slide. Supportive measures include nutritional interventions, antioxidant therapies, hormone replacement, and immunoglobulins. Intensive insulin therapy improves blood glucose control and independently reduce the incidence of this critical illness neuromyopathy. Early rehabilitation, combining mobilization and physiotherapy is also advisable. The broad differential diagnosis of acute generalized weakness in a critically ill patient includes bilateral or paramedic brain or brainstem lesions, disorders of the spinal cord, peripheral nerve lesions, neuromuscular junction disorders such as myasthenia gravis, and muscle disorders. Also, prolonged neuromuscular junction blockade may present with neuromuscular weakness related to critical illness. So neuromuscular weakness can be observed in these conditions of primary neuromuscular disorders, ICU-acquired weakness, as I have mentioned. Determining the cause of weakness is very important because it may significantly affect the prognosis of the patient. Guillain-Barré syndrome and myasthenia gravis are the most common primary neuromuscular disorders in the ICU. So let's talk a little bit about Guillain-Barré syndrome. It is an acute inflammatory demyelinating polyneuropathy. It is uncommon occurrence in the critically ill patient. It is a demyelinating polyneuropathy on nerve conduction studies, and a high cerebrofluid protein concentration may be observed. Other features may do overlap with critical illness polyneuropathy. So what are the presenting symptoms of Guillain-Barré syndrome? Guillain-Barré syndrome initially causes weakness and pins and needle sensation that begin on the legs, and these symptoms can progress up the body and become more severe, leading to paralysis of the arms and legs. There may be weakness of the facial muscles and the muscles that enable person to swallow, or of the muscles in charge of moving the eyes. Breathing muscles may be involved also. And 10 to 30% of patients with Guillain-Barré syndrome will need a ventilator to breathe. These sensations can quickly spread, eventually paralyzing the whole body. Blood pressure or heart rate can vary from high to low, often unexpectedly, and the patient may not be able to empty their bladder or may be constipated. Pain in the back, arms, or legs are common, and in its most severe form, Guillain-Barré syndrome is a medical emergency. So Guillain-Barré syndrome is a demyelinating form of disease which destroys the protective covering of the peripheral nerve or the myelin sheath, preventing the nerve from transmitting signals to the brain. So the exact cause of Guillain-Barré syndrome is unknown, but 2/3 of patients report symptoms of infection in the 6 weeks preceding. So there are several variants of Guillain-Barré syndrome, as I've listed here in this slide, and it all depends whether the affected portion of the nerve is the nose of the Ranvier or the myelin sheath covering the nerve. So what causes Guillain-Barré syndrome? So as I've mentioned, the exact reason is unknown. The immunopathogenesis of Guillain-Barré may be due to molecular mimicry and anti-ganglioside antibodies attacking the nerve itself. By infection, which may be pulmonary or gastric. Kind of recovery is expected in patients with Guillain-Barré syndrome. Most patients with Guillain-Barré syndrome worsen for the first 2 weeks, are then stable for about 2 weeks, followed by improvement. So about 60% of patients with Guillain-Barré syndrome recover completely, and about 84% regain the ability to walk by themselves at 1 year post-illness. About 4% of patients die even with treatment in the ICU. So with treatment in the intensive care unit, the prognosis for recovery is worse in patients who had gastrointestinal illness, like Campylobacter infection, as they trigger Guillain-Barré syndrome. In older patients, in people whose weakness came on quickly or who have severe weakness when they come to the hospital, and in people who need a ventilator. So bedside respiratory monitoring with the 20-30-40 rule, what does this mean? The critical values to consider intubation are forced vital capacity, less than 15 to 20 mils per kilogram body weight, with a maximum peak inspiratory pressure less than -30 cms water, with maximum peak expiratory pressure of less than 40 cms water. Cough can be measured with peak cough flow in liters per minute, where a value of less than 160 by mouth, or a peak cough flow liters per minute of less than 60 liters per minute when the patient has an endotracheal tube, may indicate potential delayed failure of extubation through inadequate clearing of secretions. So these are the common respiratory issues in Guillain-Barré syndrome: inadequate protection of the airways through bulbar weakness, non-invasive ventilation as a temporizing measure in Guillain-Barré syndrome is unhelpful. Emergency intubation of a patient in extremis is important, and effective critical care outreach after discharge from the ICU are important to avoid readmission. Almost every patient can be weaned if properly taken care of. Dysautonomia in Guillain-Barré syndrome is also may occur, and It may present with orthostatic hypotension, diabetes insipidus, cardiac arrhythmias, drug sensitivity, and ill use, which are all very common. The incidence around 20% of which may be life-threatening. Okay, and vagal spells like bronchorrhea, bradycardia, and hypotension may also occur. This algorithm describes how we can appropriately approach the management of a patient presenting with Guillain-Barré. Firstly, assess the Hugh Disability Scale score and the presence of dysautonomia. For high Hugh Disability score, we identify those patients with or without bulbar dysfunction because that will determine whether or not immediate intubation is warranted. In intravenous immunoglobulin therapy, patients are given large doses of antibodies derived from plasma from many different donors. And this may help patients with Guillain-Barré syndrome by blocking the action of antibodies that can injure nerve insulation or the nerve itself. Okay, so that's what is usually done. So in this slide, it just shows the differentiation between critical illness for polyneuropathy and Guillain-Barré syndrome. There are quite a number of similarities and differences, but the prodromal condition for critical illness polyneuropathy is mostly due to sepsis and multi-organ failure. But for Guillain-Barré syndrome, there is normally a gastrointestinal and respiratory infection that will trigger it. Let's talk a little bit about myasthenia gravis. It is a rare autoimmune disease mediated by pathogenic antibodies directed against components of the neuromuscular junction, mainly the acetylcholine receptor, the postsynaptic acetylcholine receptor. The etiology is not totally elucidated, but they include a combination of genetic predisposition, triggering events, and hormonal components. They are associated with defective immune regulation, chronic cell activation, and inflammation. Muscle fatigability may be present, very invalidating, and can be life-threatening when respiratory muscles are affected. So autoimmune myasthenia gravis is characterized by muscle weakness aggravated by exercise and improved by rest. Symptoms may fluctuate, which makes clinical diagnosis quite difficult. Myasthenia gravis is a complex disease mediated by antibodies to components of the neuromuscular junction, around 85%. And the muscle is the target of the autoimmune attack. There is diffuse inflammatory signature, which is not actually very much present in myasthenia gravis. So the basic knowledge of the structure and mechanism of the neuromuscular junction is essential to understand the myopathy secondary to the disease states that results to alteration in the neuromuscular physiology. Briefly, the postsynaptic membrane is characterized by deep junctional folds, the top of which are rich in acetylcholine receptors, while voltage-gated sodium channels are concentrated in its depth. And then at the presynaptic sites, there are actually 150,000 to 300,000 vesicles containing quantum of acetylcholine. Upon local depolarization, one quantum content is released into the synaptic cleft. The binding of acetylcholine to the acetylcholine receptor induces an entry of sodium into the muscle fiber, causing local depolarization of the membrane and forming the end plate potential. The end plate potential stimulates the opening of the voltage-gated sodium channels, and after reaching the firing threshold, a further influx of sodium ions ensues, and the action potential spreads along the muscle fiber. It reaches and opens the stocks of intracellular calcium that finally triggers the muscle contraction. So in myasthenia gravis, what happens? There are degenerative changes in the postsynaptic regions with widening and simplification of synaptic clefts and accumulation of debris in the synaptic zone. The nerve terminals are often smaller than normal size, and their sprouting may be observed. The degradation of the postsynaptic membrane results in a decrease in the expression of acetylcholine receptors and voltage-gated sodium channels. The end plate potential is also lowered because of the partial loss of functional acetylcholine receptors. So why do myasthenic patients require ICU treatment? They may present with myasthenia crisis, such as weakness and respiratory failure acutely triggered by infection, general illness, or medications mistakes in a myasthenia gravis patient. They may present with respiratory distress, pupillary dilatation, sweating, and tachycardia. How about cholinergic crisis? It is actually induced by excessive cholinesterase inhibitor treatment. Weakness accompanied by cholinergic symptoms may be observed. And also, combination of 1A2 may also occur, and patients in a crisis situation ineffectively treated with or unresponsive to cholinesterase inhibitors, that's when this actually happens. So in this slide, it shows us the relationship between myasthenia crisis and cholinergic crisis, both of which present with muscular weakness and bulbar paralysis, where there are poor ventilatory exchange and accumulation of secretions, leading to hypoventilation, reduced ventilation capacity, hypercapnia anoxemia, respiratory acidosis, metabolic acidosis, leading to CO2 narcosis, asphyxia, and death. So in terms of management of myasthenia crisis, it's important to recognize crisis early, test fatigability, not just the initial strength, check respiratory function, cough and swallowing, O2 saturation, and counting in one breath every hour, okay? Myasthenia has a more erratic course compared to Guillain-Barré syndrome, okay? So investigate for cause of crisis, such as infection and drug errors. It is important to secure the airway, intubate when in doubt, but defer tracheostomy as a rapid recovery is definitely possible. So ICU-specific aspects of myasthenia gravis, intensive respiratory therapy, and initial non-invasive BiPAP may reduce ventilatory days. Often only a short period of ventilation is needed and avoid early tracheostomy. So in the extensive information that we have gathered, here is a stepwise approach to management of neuromuscular weakness, regardless of etiology, which may be useful in the evaluation of our 77-year-old patient. So with the initial assessment, is the neurology characteristic true? Is it the true fatigue due to myasthenia gravis? Is there a flaccid tone, which may lead to Guillain-Barré syndrome? Are there historical or clinical features suggesting pre-existing chronic neuromuscular disease? Is there a family history suggesting genetic neuromuscular disease? Are there suspected toxic medications that the patient have taken? Standard diagnostic workups include we need to exclude brain and spinal cord disease, electrophysiologic testing, creatine kinase levels, and of course, other specialized investigations such as muscle MRI or CT scan, inflammatory myopathy, blood panel, and muscle biopsy, as well as genetic analysis. So in myasthenia gravis, what is important is to be vigilant with the airway and institute non-invasive ventilation early in the course of the disease to attempt to avoid the need for intubation. In Guillain-Barré syndrome, early intubation is warranted without delay if the airway is at risk to avoid further complications. In ICU-acquired weakness, failure to wean from ventilator is usually challenging. Early mobility, glucose control, minimizing sedation, and avoiding neuromuscular blocking agents remain the only therapeutic regimen available for ICU-acquired weakness. There are other differential diagnoses which may be of central causes involving the brain and brainstem or spinal cord, and this must be identified through MRI for brainstem and spinal cord lesions. Rhabdomyolysis is another differential diagnosis many develop in some critically ill patients due to their illness or medications. The potential causes may be viral, bacterial, and fungal infections, neuroleptic malignant syndrome, or serotonin syndrome, and other medications. The serum creatine kinase levels are usually at least 5 times the upper limit of normal range. Mild to moderate muscle necrosis may be observed with mild fibrillation potential activity on EMG. Other differentials are cachectic myopathy. Patients with critical illness can develop a subacute myopathy due to protein catabolism and disuse, but then the CK levels are normal. And the laboratory evidence of malnutrition can be also observed. This usually involves the type 2 muscle fibers, and normally they atrophy. Okay, so other differential diagnosis is prolonged neuromuscular junction blockade. Prolonged paralysis and ICU-acquired skeletal muscle weakness may be observed. It is quite rare. Use of paralytic agents has been largely replaced by the use of sedatives in the ICU. Following drug discontinuation, unusual and results from accumulation of drug are active metabolites or from ICU-acquired weakness. The risk of ICU-acquired weakness from neuromuscular blockers used is modest at best and may be greatest in sepsis or septic shock, severe illness, or concomitant use of glucocorticoids. Prolonged paralysis is typically related to prolonged use of paralytic agents, often in the setting of renal and hepatic insufficiency, leading to prolonged circulation of drug metabolites. Curare-like paralytic agents bind reversibly to acetylcholine receptors on the motor end plates of neuromuscular junctions, thereby inhibiting neuromuscular transmission. The critical care management of these patients requires a multidisciplinary approach. Developing an airway management protocol could have implications on the outcome and length of stay of the patient, tending to the appropriate nuances of each patient who is critically ill with a neuromuscular disorder through evidence-based medicine can also have implications on the length of stay and outcome. Neuromuscular disorders are not rare in the intensive care setting, and precise identification and treatment of these conditions can greatly impact long-term outcomes. So in terms of management, treatment of both critical illness myopathy and critical illness polyneuropathy are directed towards aggressive management of medications, avoidance of additional complications, such as venous thrombosis and rehabilitation. Minimizing sedation, limiting or avoiding use of neuromuscular blockers, and early mobilization or critical ill patients may help prevent or mitigate neuromuscular weakness. We need to reduce or discontinue the use of glucocorticoids, although it still is controversial regarding its causality. So which neuromuscular symptoms may require treatment in the ICU? Severe respiratory weakness, bulbar weakness and aspiration, cardiomyopathy and heart failure, arrhythmia, dysautonomia, acute rhabdomyolysis, and renal failure. So in terms of management, although not established, I have mentioned about the targets of blood glucose control, which is 140 to 180 milligrams per deciliter. These studies are limited by methodological issues, both for subgroup analysis and the diagnosis of CIP and CIM was made based on EMG criteria only. Okay, so another potential but unestablished therapy is neuromuscular electrical stimulation. A 2020 meta-analysis found that NMES may play a role in preventing or reducing acquired weakness in the ICU, but there is no evidence that NMES improves the functional status of ICU patients. So in terms of prognosis, many patients who survive critical illness experience prolonged impairment in cognition, mental health, and physical function. It is called post-intensive care syndrome, or PICS. Neuromuscular weakness related to critical illness is often a significant aspect of the syndrome, with sequelae that may include persistent generalized weakness, joint contractures, poor mobility, falls, and disabilities in activities of daily living. The presence of intensive care unit acquired neuromuscular weakness at discharge may also negatively impact 5-year morbidity and mortality. So in terms of SIM, it is usually reversible over weeks to months, leading to prolonged ICU stays and increased length of hospital stay overall. In terms of CIP, residual nerve dysfunction may persist years after initial presentation and may persist up to 12 months after discharge from the ICU, and the patient may remain quadriplegic for quite some time. In summary, suspected in patients who develop flaccid muscle weakness and ventilatory failure after the onset of critical illness. So diagnosis is confirmed when other unrelated causes of weakness are excluded or deemed unlikely. Neuroimaging is indicated if the neurologic assessment of weakness is unreliable or if the evaluation reveals evidence that raise suspicion for a central nervous system lesion. Electrodiagnostic testing, nerve conduction studies, electromyography, and repetitive nerve stimulation for all patients who have unexplained severe weakness that does not improve over 1 to 2 weeks. So in terms of differential diagnosis, there could be organic lesions in the brain or the brain stem or even the spinal cord. Other acute and subacute myopathies can occur, such as rhabdomyolysis and cachectic myopathy. And rare acute neuropathies, such as neuromuscular disorders of Guillain-Barré, can also develop, as well as subclinical myasthenia gravis, may become symptomatic during critical illness or treatment of IV magnesium and some antibiotics. These are my reference. Thank you very much. Also, we would like to thank the organizing committee for this opportunity to make an announcement about an upcoming activity. The Society for Neuroanesthesia of the Philippines would like to cordially invite you to the 7th Asian Society of Neuroanesthesia and Critical Care, a hybrid congress entitled A Synapse of Minds. It is a collaborative and multi-specialty meeting that will serve as a venue where there can be exchange of valuable concepts, innovative ideas, and best practices among Asian countries and the rest of the world that may be beneficial to the neurological and neurosurgical patient, and this will be held in February of 2023. Further announcements will be made soon. We welcome you to the Philippines in 2023. Mabuhay. Thank you very much.
Thank you, Professor Geraldine, for a very nice presentation and very informative. Also for announcement ASNA Congress at Philippines. We hope all of us will come to Philippines if COVID-19 is gone.
Yes, thank you. Thank you very much.
And I invite the next speaker, Dr. Chong Sang-yi. Dr. Chong works as a consultant at Department Anesthesia, Pain and Intensive Care Medicine, Tan Tock Seng Hospital, Singapore. She will talk about update on tranexamic acid use in aneurysmal subarachnoid hemorrhage. Dr. Chong's time is yours.
Hello, good afternoon or good morning, everybody. Selamat pagi. Thank you, Prof. Tatang, for the kind introduction, and I hope everybody can hear me. It is always nice to meet everybody here again. The last time I was in Indonesia was 2 years ago, also to present at an ICU conference. So with COVID, I hope we will see each other in person again soon. Okay. If I may, I would like to start to share my screen now. Please give me a short second while I set up. Can everybody see my screen?
Yes, nice.
Okay, all right, thank you. Now, I shall begin because I realize that mine is the last talk of this conference and I'm the only barrier between all of us and lunchtime. Okay, so today I'm talking about the use of tranexamic acid in aneurysmal subarachnoid hemorrhage. I would like to casually ask everybody if tranexamic acid is something that you use commonly in your practice, whether it be for subarachnoid hemorrhage or not, but this is what we are going to concentrate on today. So this is how it looks like, maybe in your hospital, or maybe in mine, the vial comes, but it comes usually in a 1 gram per 10 ml vial or a 500 milligrams in 5 ml vial. Okay, just to refresh our memory, what is tranexamic acid? Tranexamic acid is actually a synthetic derivative of the amino acid lysine. And what it does is that it binds the 5 lysine binding sites on plasminogen. So With this, you can see that TXA will block the lysine binding sites on plasminogen. This will then prevent the formation of plasmin. And plasmin is responsible for degrading fibrin into fibrin degradation products. So ultimately, tranexamic acid is an antifibrinolytic. Okay? It inhibits fibrinolysis. Okay? Additionally, it may also have an anti-inflammatory effect and may also improve platelet function in certain circumstances. Okay, so we give it to help with bleeding. Okay, I think tranexamic acid has been studied a lot in the literature, and we know that the history of tranexamic acid dates back all the way to Japan after World War II. But with Japanese research, and they started looking at ways to use tranexamic acid. Very popular uses of tranexamic acid include its use in the obstetric or in the postpartum circumstances, in trauma, and even in elective surgery. For example, in my institution, we give it quite a lot routinely for elective total knee replacements or joint or even spine surgeries. Okay? Now, these are some of the more hallmark trials on the use of tranexamic acid. I would just like to highlight that even though its use is very common and ubiquitous, it is not as if tranexamic acid is without its controversy. And sometimes the evidence for its use may not exactly be grade 1 or grade 1A. Okay, so this is just to sum up. Now, how about looking at aneurysms and subarachnoid hemorrhage in general? I would like to remind everybody that we are now in the year of 2022, and there's a lot of advancement in our healthcare, but mortality rates for aneurysmal SAH are still quite high, at 32 to about even 2/3, and 1/3 of the survivors actually remain dependent. So aneurysmal subarachnoid hemorrhage remains a healthcare problem that is of high morbidity and mortality. In addition, we need to know that in subarachnoid hemorrhage, rebleeding is a very big and one of the most major concerns. We know, and this has been validated many times, that in patients with aneurysms and subarachnoid hemorrhage, rebleeding from the ruptured aneurysm will increase the risk of poor clinical outcome and all-cause mortality. So the more you rebleed, the higher your risk of morbidity and death. Now, when do people rebleed the most after the initial subarachnoid hemorrhage? There is a high rate of rebleed during the first 24 hours, and then it is estimated at around 1.5% per day. So in the first 2 weeks of presentation, about 20% will have rebleed, and it slowly drops from then on. Okay, and we know that there is a high mortality associated with this. So indeed, what is recommended in global guidelines is that early aneurysm treatment is recommended. The earlier we institute treatment to secure the aneurysm, whether it is by coiling or clipping, it is better, because obviously then once the aneurysm is secured, there will be no problem of rebleeding anymore. Okay. But of course, what we are trying to look at is to use tranexamic acid to prevent or to help maybe with the rebleeding part of the process before definitive aneurysmal treatment is instituted. So with regards to antifibrinolytic treatment and aneurysm SAH, what research was done in the past? There were not very many papers, but there were a few of them. Okay, notably in 1984, which is about 40 years ago now, it has been shown that the beneficial effect of long-term tranexamic acid, they gave this throughout the patient's hospital stay, and this helped with rebleeding. That means the patients had less rebleeding, but this was offset because any favored outcome in favor of TXA was offset by an increased risk of delayed cerebral ischemia, DCI, or vasospasm, and therefore overall there was no beneficial effect. Okay. In the year 2000, they also looked at long-term, which means throughout the hospital stay, using TXA, and they said, okay, since vasospasm and delayed cerebral ischemia seems to be a problem, let me try and counteract that by maintaining normal volemia and giving nimodipine treatment. So it has been shown that the rate of rebleeding did decrease without an increased risk in delayed cerebral ischemia, and this seems to be favorable overall. But when they look at the patients who were treated with tranexamic acid and who ended up still with poor clinical outcome, they found that these people still had delayed cerebral ischemia, meaning to say that delayed cerebral ischemia might still be a problem with antifibrinolytic treatment. I found this Cochrane review, systematic review done specifically on antifibrinolytic therapy for aneurysmal SAH. This was done in the year 2013. It showed overall that the antifibrinolytic treatment did reduce the rate of rebleeding by about 35%, but there was no real benefit on case fatality or even on overall outcome, principally because, like we already started to talk about, that there was an increase in cerebral ischemia with antifibrinolysis. One trial actually compared using short-term, which means instead of using throughout the hospital stay, they gave tranexamic acid immediately after diagnosis for up to 3 days. And they showed that, oh, this did not only help with rebleeding rates, but that there was also a decrease in delayed permanent neurological deficit. But the study was only powered to reduce rebleeding and not powered for neurological outcome. So that was actually an inferred outcome. And this is the study. It was published in 2002. If anybody is interested, I can supply the paper later. Okay? But because this study favored TXA and some other studies as well, up to 2012, this is the American Heart Association guidelines for stroke in June 2012. And you can see that one of the guidelines still states that for patients with an unavoidable delay in aneurysm securement and with a significant risk of rebleeding and no contraindications, short-term, less than 72 hours therapy with tranexamic acid or aminocaproic acid, which is another pharmacological agent, is reasonable to reduce the risk of rebleeding. So these were in the guidelines up to recently, and the use of TXA was also, in fact, in my hospital guidelines until recently, which was after the publishing of this paper. So this paper is what I will focus on for the rest of my talk today. It is called the ULTRA trial, ULTRA meaning ultra early tranexamic acid after subarachnoid hemorrhage. Okay, this is a trial that is quite well designed. It is a prospective randomized controlled trial with a pragmatic design. However, it is open label and only the assessment part was masked. We might talk about that in greater detail later. This study was conducted in the Netherlands, looking at 16 referring hospitals and 8 SAH treatment centers, giving a total of 24 sites. And data was collected over 6 years from 2013 to 2019. So what they wanted to do was that they wanted to try and optimally reduce the rate of rebleeding without having an increased risk of delayed cerebral ischemia. So let's look at how they did that. Like I said, this was the design of the trial. It is a randomized open label trial. They calculated a total participant number of 950 for an 80% power with an 8.1 difference with the alpha error set at 0.05. And they also said in the beginning that they would analyze the data with intention to treat analysis as well as per protocol and as treated type of analysis, which I find to be very good. The inclusion criteria was any adult 18 years old and above who was admitted to one of the 24 sites with signs and symptoms indicative of SAH for less than 1 day, and a non-contrast CT scan confirming the presence of subarachnoid hemorrhage. The exclusion criteria I thought was also very good. They excluded people with a different type of bleeding pattern. They excluded traumatic SAH. They excluded patients who had concomitant problems such as renal impairment, any hypercoagulable problems, if they were otherwise already undergoing treatment for DVT or pulmonary embolism, or if they were pregnant, or if the diagnosis was quite severe such that they were expected to have an imminent, unfortunate demise in the next 24 hours. So the principle of this trial is to give the tranexamic acid ultra early, which is not like what they used to do in the past throughout the hospital admission, and it's not also for up to 3 days. So what they did was the moment the patient was diagnosed with SAH on a non-contrast CT scan, they gave a 1 gram bolus followed by a 1 gram infusion every 8 hours. And this would continue until either the start of coiling or clipping or up to 1 day, which is 24 hours, whichever came first. That means we started as early as possible, and they also stopped it as early as possible. So of course, the treatment is stopped, if either of these criteria are met, or if, for example, the patients or families refuse treatment, or if they discovered with later imaging that the SAH was actually non-aneurysmal in nature, or if there was no aneurysm seen. And what was the primary endpoint? The primary endpoint that they measured was clinical outcome, which is rated on the modified Rankin scale, which is like an assessment or a disability scale. It was done at 6 months through a telephone interview by masked assessors, and there was a dichotomy between good and bad. Now, I would like to highlight to everybody that MRI scores range from 0 to 6. It is a subjective scoring, and the dichotomy of good and bad, there is no universal threshold, so it is up to the authors to decide. Okay. Now, for this study, they also looked at secondary outcomes, meaning they tried to stratify the scores a little bit more, with a little bit more granularity, and they also looked at all-cause mortality at 30 days and 6 months, which is quite standard. Now, being a prospective randomized control trial, we can see that the participant characteristics are actually quite similar in nature. Most of them had WFNS grade 1 subarachnoid hemorrhage, and you can see that there were no significant differences between the participant groups. Now, looking at the trial allocation profile, I'm not sure if the diagram can be seen very clearly, but the average age of patient recruitment is 58.4. About 2/3 of them were female. The average time from symptom onset to having a scan that diagnosed SAH was 93 minutes. The average time from symptom onset to giving the TXA treatment was 3 hours. The average time, or the median time, to start aneurysm treatment after the diagnosis is 14 hours, which is very, very quick. And if any of the patients had their treatment discontinued, just over half of them was because the aneurysm was going to be secured, and about 15% was because it had been more than 24 hours already. So you can see they managed to recruit 955 patients, and in the end, they analyzed 475 in the TXA group and 470 in the control group. So the fallout rate was very, very low. So it was quite well organized that way. There was no real loss of data. So the important thing is now let's look at the results. This seems to be like a very busy slide, but let me just summarize it for you guys. Now you can see that in terms of the primary outcome, or in short, what we said was that the study did not favor the use of tranexamic acid in this manner or setting. Okay, if you look at primary outcome, with a good clinical outcome, you can see that it is not statistically significant. The odds ratio was 0.7 with a confidence interval crossing 1. In fact, if you look at the absolute numbers, it might seem that tranexamic acid can do a little bit worse. Now, if you look at the secondary outcomes, which looked at excellent outcomes, it is also about the same. In fact, tranexamic acid might do a little bit worse. Okay. The authors analyzed the data quite well, so they also did ordinal shift analysis to account for different effects at different treatment centers. Okay, and if you looked at this distribution of the MRS score at 6 months, you can see that follow-up rate was very, very low. Loss to follow-up rate was very, very low. Only 10 patients were lost to follow up, and there was no statistically significant difference between the two groups in the overall distribution of the scores. But you can see maybe, just to our naked eye, it seems like having TXA might be slightly worse, in fact. Okay. Now then, because any treatment comes with it risks and adverse events, or side effects. So the authors also looked at adverse events for this study. So to summarize, there was actually no significant difference in adverse effects. Okay, serious adverse effects were about the same, with the odds ratio being 1.14. They looked at bleeding, which was also not significant, and they looked at delayed cerebral ischemia, which is what we're very concerned about. Also no statistical significance. And neither were there any significant differences in clotting problems or thromboembolic complications. Okay, so in conclusion, with this ultra trial, what we can say from this paper alone is that in patients with a spontaneous CT scan proven subarachnoid hemorrhage, presumably caused by a ruptured aneurysm, ultra early tranexamic acid treatment initiated immediately after diagnosis with a maximum treatment duration of 24 hours did not improve clinical outcome at 6 months. Okay, did not improve clinical outcome. I feel that this paper in the Lancet had quite a number of strengths. The design of the study was good. They followed very well best practice of early aneurysm treatment. Remember, the median time to treatment was 14 hours, which is really, really quite good. I like that the paper was powered for a meaningful primary endpoint, which is clinical outcome and not just rebleeding, which might not be very meaningful to the patient or the caregiver at the end. Okay, they also analyzed the data quite well and did adjusted odds ratios. Okay, they also tried to do ordinal shift analysis, and they analyzed the data with intention to treat as well as treated. Although the crossover rate was not very high, and there was no difference in any of this data. Okay. However, as with any study, there are also weaknesses. So the problems with this paper, or the criticisms, come from the fact that patients were unblinded at treatment, and we all know that this always causes bias. Okay, although of course, if you are talking about death and significant outcomes like this, it is quite binary. Now, the second thing that we need to note is that even though there were 24 sites, this study was only done in the Netherlands, which is a very, very developed country. And therefore, we may not be able to extrapolate this data entirely across the world and every country across in the world as well. Now, we also need to note that in this study, 14% of the patients recruited ultimately had no aneurysms seen. And of course, then this will affect the outcome of the study. But because this paper deals with ultra early, they specifically said that they would not wait for the diagnosis of an aneurysmal SAH to be made. So once there was SAH on the CT scan, they would first start to institute treatment. So I'm not sure if this could have been mediated. Now, the true efficacy of tranexamic acid was also maybe not potentially caught, because the median time to giving was actually about 3 hours. And if we reference to previous trials done with TXA, such as the CRASH 2, CRASH 3, they always try, or the target time frame to give TXA was always within 3 hours. So we are just at the borderline or just at the boundary of 3 hours. We are not sure whether giving it earlier may even prevent some rebleeds. Okay. Additionally, in this study, not many patients had rebleeds to begin with, so that may have skewed the effects slightly. Okay, but the last thing also is that the modified ranking scale is always a subjective scoring system and is scored by one person. So over here, they tried to use multiple assessors, but there's always a problem with intra-rater and inter-rater reliability. Okay, so I think this trial is strong, but it is not perfect. But usually what happens is that the trials may favor the treatment a little bit, but this one really does not. In fact, it might seem to favor the control more. Okay, so I'm coming to the end of the talk. With all this, what should we do? I asked myself a few questions, which I will ask you as well. So should we give tranexamic acid for the entire patient's treatment duration or hospital stay? I think the answer is no. Those were the very early papers that were done, and it did show that delayed cerebral ischemia was a real problem. So should we give TXA for aneurysmal SAH then in the first 3 days, like that paper published in 2002? The answer is not really as well, because that paper, although it showed it favored tranexamic acid, it was not powered for clinical outcome. It was only powered for rebleeds, for which tranexamic acid was useful, but it may not be so useful in overall clinical outcome. And then the third question is, should we then give tranexamic acid in the first 24 hours? And this is where the ultra trial comes in. And we've talked about the trial. I think the answer generally is no, we should not. Okay. And then they said, okay, since the study showed that, it took them 3 hours to initiate TXA treatment, should we then give it in the ambulatory setting? That means on the way to the hospital, quickly, once the patient presents with signs and symptoms? I would say definitely no as well, because there are many, many other problems and diagnosis that may present with symptoms like SAH. For example, some of our esteemed speakers talked about cerebral venous sinus thrombosis this morning, and that very, very largely presents with headache. You certainly will not want to give TXA in a patient with cerebral venous sinus thrombosis. So I think this answer is also no. Okay. I think my last big point is that we now know that routine use of tranexamic acid in aneurysmal SAH is not standard of care and is not recommended, because there is no clear benefit. But we need, not that it is totally useless, but we might need to define patient groups a bit better. We might need to try and achieve the proper timings a little bit better. But because of the potential risk still of delayed cerebral ischemia, I will not routinely give it in my practice. Okay. In fact, with this talk of mine only talks about TXA, but we cannot forget that as anesthetists and intensivists, the treatment of aneurysms and subarachnoid hemorrhage is not just about TXA. There are many, many things we can do to try and improve outcome. First of all, to stick to best practice guideline of early securing the aneurysm. Okay, we understand that this may not be possible in all circumstances and institutions, but we must keep that at the back of our heads. The second thing that we can really do is to have good blood pressure control. Okay, indeed, the rupture of an aneurysm depends on the transmural pressure gradient. So if we better treat our MAP and our ICP, we will reduce the transmural pressure gradient and also therefore be able to reduce the rate of rupture and the rate of rebleed. Okay, if this patient is coming to us for aneurysm clipping or coiling, a good anesthesia technique which prevents surges in blood pressure and very good titration of blood pressure management as well as transfusion management is also very, very important. And of course, to have the patient monitored in a facility that is able to detect any complications early so that we can mitigate them, that's important as well. Okay, so there are other aspects of aneurysmal treatment, such as addressing the complications like pulmonary edema or myocardial stunning, and also not to forget other guidelines, for example, the early giving or the timely institution of nimodipine treatment to prevent vasospasm, and also vasospasm monitoring, whether it is from monitoring GCS or by the use of TCD, because vasospasm is one of the biggest causes of delayed cerebral ischemia. So that should be addressed as well. Okay, I think I've come to the end of my talk. Thank you very much. I will be glad to answer any questions if there are any. Thank you.
Thank you very much, Dr. Chong Sang-hee, for very nice presentation. And now it's time for discussion. The question in question and answer column. Yes. The first, no question for Professor Hye-Kyo Kim because he is not here. And this is question for Professor Geraldine. Professor Geraldine, can you see the question?
Yes, Professor Tatang, thank you. Yes, I could read the questions. So would you like me to answer the questions?
Yes, please.
Okay. For the first question, is there recommended investigations to exclude other causes of muscle weakness before diagnosing critical illness myopathy and critical illness polyneuropathy? Just to say that the most common cause of neuromuscular weakness in the ICU is the critical illness myopathy and polyneuropathy. So that is actually the most common. And therefore, the neuromuscular disorders that may be observed in the ICU are quite rare, which I have mentioned earlier, which are Guillain-Barré as well as myasthenia gravis. So other than doing electromyogram and nerve conduction studies, these are actually the diagnostic tests that can be done, as well as cerebrospinal fluid assessment. And with this information, we can therefore document whether the cause of the muscle weakness is due to this neuromuscular disorders or due to the critical illness of the neuromuscular critical illness. So those are the things that can be done to rule this out. Of course, other organic causes should also be assessed, like if it's a brain or brainstem or spinal cord lesion, then therefore all these things can be done to rule out other causes based on the clinical picture of the patient. So I hope I answered your question. The second one, when can we start to rehabilitate critical ill patients with mechanical ventilation? What is advisable is, as long as the patient is hemodynamically stable, we can do early rehabilitation, even if the patient is still intubated, by having range of motion exercises and doing TENS, electrical nerve stimulation. All these things can actually help the patient while in the ICU. Other things can be done, such as kinetic energy, moving the bed of the patient in such a manner so that there is less pressure on certain areas of the body, especially in the supine position. So we have to avoid venous thrombosis, so that by the time that the patient is ready and is more clinically stable, then we can expect recovery. But then again, it depends on what type of neuromuscular disorder the patient has. So third question, how about your comments on plasma exchange for myasthenia gravis or Guillain-Barré? Basically, of course, this is the one of those treatment options that can be done. But then again, we need to differentiate first whether it is due, if the neuromuscular disorder is due to myasthenia gravis or due to Guillain-Barré. Just by history alone, history of infection, pulmonary and gastrointestinal, then we could say it's a Guillain-Barré. And basically what is being said in the literature is to give IV immunoglobulins to the patient over a certain period of time, and also supportive therapy, because the most important thing is to treat the infectious process, sepsis, SIRS, or any other medical conditions of the patient, stabilize the electrolyte profile of the patient. All these things should be addressed. And that last resort would be the use of plasma exchange later on, if all other parameters were not able to help the patient to be better. Thank you.
Thank you, Prof. Geraldine. Any other question? Yes, the question to Dr. Chong Sang-hee. Dr. Chong, can you see the text on the screen?
Hi, Prof.
Yes. Can you see the text on the screen?
No.
Yes. Two questions.
I can see one question in the Q&A.
Yes.
Yes.
Please, you answer.
From Dr. Pristanova.
Yes, right.
All right. Let me just read the question. Okay. The question is that where if we do not have definitive treatment like coiling or clipping readily available, and it might take more than 72 hours, should we still give tranexamic acid to reduce the chance of rebleeding? Now, I think this is a very good question. Thank you for that. In summary, I think there is no easy answer, because a lot of the papers have shown that that tranexamic acid does help with rebleeding, as with the problem of aneurysmal rebleeding. And of course, the later it is that we secure the aneurysm, theoretically there might be a higher chance of rebleed. However, if you ask me whether I would still give tranexamic acid in this setting, I think it would no longer be something that I would give, or rather I will try my best not to give it. mainly because of the problem of delayed cerebral ischemia and vasospasm. So I think in my talk, as I was thinking about things, I think that there are many other things that we can do, and there are some things that I will really pay attention to in this instance, which would be number one, I will try my best to shorten the time that the patient gets definitive aneurysm treatment. I'll try my best to ship the patient off to a good neurosurgical center without delay and all those logistic concerns. Additionally, I will make sure that my blood pressure control is very good. And I would really try and strictly control my blood pressure, because we do know that in patients with uncontrolled blood pressure or having swings in the blood pressure, the rate or the chances of rupture are also very high. Now, the third thing that I think that can be done will be that in some of these in these patients with aneurysmal SAH, we need to then also, be ready to monitor them very well, such that unfortunately, if there is such a problem, it can be quickly addressed. And also this means that we need to do other investigations, and we might need to repeat them if we are waiting for up to more than 3 days or so. And these investigations, particularly, I would look at things like anemia. I will also look at things like whether or not the patient has concomitant coagulopathy. I will look at whether or not the patient was on any medications like antiplatelets or anticoagulants that may necessitate reversal of the agent. And all this will also, I believe, decrease the risk of rebleeding. One thing to remember is that I won't say that tranexamic acid is useless, but I think the effects are also dose dependent. So it has been shown in some of the studies, because some of the studies used up to 3 grams of tranexamic acid, right? Because if you give 1 gram every 8 hours, in 24 hours, you will give about 3 grams. If you give for up to 48 hours, it'll be 6 grams. And in the studies that gave for more than 3 days or so, you easily give more than 10 grams of tranexamic acid, which is quite a big dose. So I would say that even if there's nothing else I can do, and I just want to try it and give some tranexamic acid, I believe that maybe 1 dose may not be very harmful, but to keep giving it 8 hourly for more than 3 days will certainly then carry a very increased risk of the delayed cerebral ischemia later on. Yeah. Thank you. Oh, I can't hear anybody.
Sebentar, Bu.
Hello?
Yeah, hello, Dr. Sanggi. Hello, Dr. Geraldine and Dr. Symposium. Sorry, I think
maybe I think Prof. Tatang is left from the
left from our Zoom, and he tried to connect to us again.
Okay, that's okay. Yeah.
Okay, well, maybe we should wait for a moment so Prof. Tatang can join us. Thank you so much, Dr. Geraldine and Dr. Sanggi, Dr. Buyung.
See you again.
Yeah.
Dr.
Yeah.
Geraldine.
Okay. This is Prof. Tatang has joined us. Yeah.
Oh yes. Okay.
Hello.
Welcome, Prof. Tatang.
Welcome. I'm sorry.
It's
So
okay.
sorry.
It's okay.
I change to my handphone now.
Okay. Handphone is good.
Please, Dr. Chong, to answer the question.
Yes. Just answer it.
Now, Dr. Buyung.
Yes.
I don't know, because for a minute I lost.
Oh, I have already answered the question.
Already answered the question, Prof. Dr. Chang. Yes. This next question is nice answer from Dr. Chang.
Yeah. And now the other question. Any other question? Please, the committee show the question to the screen.
There are
I
other.
think
Thank you.
I think all the panelists already answered the questions, Prof. So maybe you can close our session.
Okay.
Thank you.
Okay. Thank you very much to all speakers. Also, thanks to all audience and the committee. Dan selanjutnya saya kembalikan ke MC. Thank you very much.
Thank you.
Thank you, Prof.
And see you soon.
Thank you. See you.
Thank you. Tidak difoto
Thank you,
dulu.
speakers and moderator, for the second session of plenary lectures.
As for the last photo session, we kindly invite all the panelists and moderator from yesterday and today's event.
Dr. Wong Yulin from Singapore.
Professor Siti Shasnak Saleh from Indonesia.
Professor Kwek Thong Hiap from Singapore.
Dr. Iwan Abdul Rahman from Indonesia.
Dr. Pim Wang Sukplung from Thailand.
Professor Dash from India.
Dr. Kananga from Indonesia.
Dr. Tu Tianming from Singapore.
Professor Masahiko Kawaguchi from Japan.
Dr. Sudadi from Indonesia.
Dr. Chong Ching Ted from Singapore.
Dr. Long Kok Weng from Malaysia.
Dr. Iputu Pramana Suarjaya, Bali, Indonesia.
Professor Haekyu Kim from South Korea.
Dr. Buyung Hartio from Indonesia.
Dr. Geraldine Rapaila from Philippines.
Dr. Chongshang Yi from Singapore.
Please kindly open the camera.
Thank you, MC. I think Dr. Geraldine has left us. And please, Dr. Chong Chintet and Dr. Sanggi and Dr. Yulin, if you are still with us, can you open the camera, please? Thank you so much, Dr. Sanggi. Okay. Yeah.
Thank you.
Now we are at our end of the event. It was really fun and also very sad that we have to be a part of this event.
Thank you to all speakers from various countries who are willing to take their time so that this event can run smoothly.
Thank you to all moderators who have guided this event very well.
Thank you to the head of the event who has planned and designed the big event so perfectly.
Thank you for our sponsor who done their help.
Thank you to all the participants who have been willing to participate and attend this big event.
The truth now unfold, the story is now told.
Crying eyes, hidden lies, just too many goodbyes.
Today is before and I have to close the door.
Sorry, it's not a lie, and now we have to say
Goodbye.
As for our anesthesiology Lambung Mangkurat University mottos, nil sine Newman, les desperandum, dum spiro spero.
Nothing happens without God's will. Don't give up. As long you are still breathing, there is hope.
I am Ada Rahmayanti.
I am Vesta Antares. Farewell to resign. See you on our next big event. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Semuanya terima kasih. Mohon maaf ada kesalahan.
Thank you everyone. Bye bye.
Thank you, Dr. Cintet. Thank you. Nice to meet you.
Thank you, Dr. Cintet.
Thank you. Bye bye.
Sampai ketemu di video
Thank you, Dr. Himawan.
membawa rakit bagandengan bahanyut matan di udik barito awal hari baganti minggu siang dan malam waktu hari baganti hari istilah orang mencari rajaki kada tak lepas lawan gawi panas hujan kada menjadi papan tangan kada hiram tetap dirasakan menambat batang sambil berami-ramian akhirnya sampai ke tujuan inilah nasib menjadi orang pembatangan lamun nasib sudah ditentuakan insya Allah ada harapan. Panas hujan kada menjadi papan tangan kada hiran tetap dirasakan menambat batang sambil berami-ramian akhirnya sampai ke tujuan inilah nasib menjadi orang pembatangan lamun nasib sudah ditentuakan insya Allah ada harapan insya Allah ada harapan insya Allah ada harapan. Pisang silat, pisang timbatu aku gangan akan bercampur juga amun jadi tulak apa sanggupku sahih berdoa iman di dada sembah sujud ampuni dosa kasih kasih satu mat dalam dunia. Kilir-kiliran si banyu mata, kampung nan jauh bakal ku tuju, kampung nan jauh ku tuju. Mulai lawan bismillah, batis nang kanan ku langkahkan, lalu tawakal Allah. Itu jadi sangguku. Mulai lawan bismillah, batis nang kanan ku langkahkan, lalu tawakal Allah. Itu jadi sangguku. Gambus. Jadi sangguku. Mulai lawan bismillah, batis nang kanan ku langkahkan, lalu tawakal Allah. Itu jadi sangguku. Sembah sujud ampuni dosa, kasih satu mat dalam dunia. Kilir-kiliran si banyu mata, kampung nan jauh bakal ku tuju, kampung nan jauh ku tuju. Ya Allah, ya Allah, kampung nan jauh ku tuju. Sapu tangan babuncu ampat, sabuncunya dimakan api, dimakan Tabang bamban jangan diparit, mun diparit buang ke sumur, buang ke sumur. Luka nang di tangan, kawa di baban, luka nang di hati, hancur sekali. Sapu tangan babuncu empat, sabuncunya dimakan api, dimakan api. Tabang bamban jangan diparit, mun diparit buang ke sumur, buang ke sumur, yeah. Rindang pangdandang jangan diharit, lamun diharit membawa umur. Oh no, yeah. Sapu tangan, sapu tangan babuncu ampas. Oh yeah, sapu tangan babuncu ampas. Oh yeah, sapu tangan, oh yeah. Tarik cel, nyaman benar kene bakayuhan lah. Oh banyak, itu nah benar untai-untai dalam tapeh tuh. Luka nang di tangan, kawa di baban, luka nang di hati, hancur sekali. Rindang pangdandang jangan diharit, lamun diharit membawa umur. Gugurnya melintang mencari si jantung hati. Aduhailah sayang, daun si daun dadap, daun dadap gugur melintang, daun si daun dadap, daun dadap gugur melintang. Gugurnya melintang, basunting si kambang melati. Gugurnya melintang, basunting si kambang melati. Aduhailah sayang, bulan si bulan kadap, bulan kadap basuluh bintang, basuluh cinta mencari si jantungan.